Yung mga doctors, talagang inaalam nila ang karamdaman ko. And pinapaliwanag nila yung assessment.
And because accessible ang records ko anywhere within the network, pwede ko ituloy ang treatment ko kahit sa ibang accredited centers.
Madalas nga may iba pang experts at doctors na pinapatawag. They consult and share their findings.
I propose that Ateneo consists
welcome to the 4th Annual Health Leadership Summit. Business Development Team, a BS Health Sciences graduate from Batch 2016, and a member of the UPCM class of 2022.
Good morning. I am from the Ateneo Law School, and together we are delighted to be your host this morning.
So Marian, are you excited for what's in store for us this morning?
Of course, and I'm sure all of our guests and participants who came here on a rainy morning are very excited too. But some of you may be thinking, what's happening today, Rafa?
Exactly. It might be a bit confusing as to why we're all here today. Well, the Health Leadership Summit, or HLS for short, is an annual conference organized by AC Health and the Ateneo Professional Schools with the objective of advancing healthcare in the Philippines, especially in the context of the universal healthcare. This year's HLS will revolve around the topic of Human Resources for Health, or HRH, also known as Health Human Resources, Healthcare Professionals, or the Health Workforce. It's a mouthful, but it's something worth discussing.
Yes. And indeed, the topic of human resources for health is very important. Filipino healthcare workers are sought globally because of your excellent skills and compassionate patient care, which is also why we're seeing a shortage of healthcare workers locally. And we hope that through this morning's discussion, we can harness insights to better understand the issue of HRH and develop strategies to develop the challenges related to it.
So I hope everyone had a good breakfast because we have a jam-packed program this morning, headlined by notable speakers, expert panelists, and special guests. So without further ado, let us begin our program for this morning. May we request everyone to please rise for the singing of the Philippine National Anthem.
Please remain standing for the invocation to be led by Attorney Jose Maria Hofelenia, Dean of the Ateneo School of Law.
As we begin this year's summit, let us first quiet ourselves, and in this brief moment of silence, let us allow the Lord to fill us with His presence. Dearest Lord, as we come together once again in this Health Leadership Summit, our fourth such summit, to share anew our time for reflections on and commitment towards working to cause universal healthcare to become a meaningful reality for those who need healthcare and for those who provide it, we ask for your grace. We ask that you fill our hearts with the grace of humility and genuine generosity, that we may acknowledge the needs and the cries of others, especially those in the peripheries, and promptly respond to their call, and in so doing, to feel the sense of purpose and experience the joy in being of service to them in sickness and in health. We ask that you fill our minds with the grace of wisdom, that we may discern the most essential and effective way for us to contribute towards achieving, in the words of the enunciated state policy, to protect and promote the right to health of all Filipinos and instill health consciousness among them. We ask that you fill our resolve with the grace of courage, that we may endure and sustain in this our common mission to proactively remain relevant to those in the front lines and those in the back rooms of the Philippine health sector. Finally, we ask you to keep everyone safe against the consequences of this present inclement weather. All these we ask of you, Lord, knowing that whatever we do for the least of our brothers and sisters, we do for you. Amen. Saint Ignatius of Loyola, pray for us. In the name of the Father, Son,
You may now all be seated. So to formally welcome everyone to this year's Health Leadership Summit, it is my pleasure to introduce you to the President and CEO of Ayala Corporation, Mr. Cesar P. Consing.
Department of Health Secretary Dr. Ted Herbosa, Ateneo de Manila University President Father Bobby Yap, and Vice President for Education Dr. Marlu Vilches. Our keynote speakers, Dr. Kun Suit from the Thailand Ministry of Public Health, accompanied by Dr. Kun Kanang from Mahidol University, and Director Johanna Banson from the DOH Health Human Resource Development Bureau. Our expert panelists and moderator, Dean Dodi Alfonso, Undersecretary Hans Kakdak, Dr. Kenneth Hartigan Go, Dr. Rosel Tolentino, Mrs. Gaget Bengzon, and Dr. Jean Solante. My fellow AC Health Board member, Mr. Albert Larrazabal, AC Health President and CEO, Mr. Paulo Borromeo, together with the rest of the AC Health leadership team, deans of the Ateneo Professional Schools, namely Dean Joey Hofilenia from the Ateneo School of Law, Dean Randy Tuanyo from the Ateneo School of Government, and Dean Jet Magsaysay from the Ateneo Graduate School of Business, along with other members of the academe, health industry partners, friends from government agencies, esteemed guests and students, good morning from a true green Lasalite. Welcome to the 4th Annual Health Leadership Summit, organized by AC Health and the Ateneo, to discuss how to truly realize universal health care in our country. This year's theme, entitled Human Resources for Health in the Light of Universal Health Care, is particularly important. Simply put, the Philippines just doesn't have sufficient doctors, nurses, and other healthcare practitioners to realize the promise of universal healthcare. In recent testimony to the Senate, Erwin Enad of the Professional Regulatory Commission stated that only 510,000 of our almost 1 million registered nurses are active, with over 300,000 now abroad, and the rest working at different jobs here at home. As for doctors, he testified that only 95,000 of our 160,000 registered doctors are active. Commissioner Enad added that, based on optimal staffing standards, the country needed 126,000 more nurses, or 25% more than what we have today, and 116,000 more doctors, or 120% more than what we have today. COVID highlighted these shortages and probably exacerbated them. Put another way, we have less than 5 nurses and 1 doctor per 1,000 people. In contrast, Canada, with a universal healthcare system that many countries want to emulate, has 11 nurses and 3 doctors per 1,000 people. Our country, with GDP per capita of $4,000 more or less, spends about 6% of GDP on healthcare. That translates to about $200 per person per year. Canada, with GDP per capita of $52,000, spends 11% of GDP on healthcare. That's $5,800 per person per year on healthcare expenditures. The differential in expenditures translates into large differentials in supporting infrastructure and facilities, and ultimately translates into differential in compensation and rewards. It's no wonder that we are losing our healthcare professionals to countries like Canada. One reason we don't have enough nurses and doctors is that those we produce are so good, and what we offer them just isn't good enough. In my job, I meet quite a few ambassadors from the largest Western countries and ministers from all over. The single most common question I am asked is, how can we get more of your healthcare professionals? My stock answer is that any foreign program to import more of our healthcare professionals must invest in the growth of our country's healthcare system in terms of people and educational and healthcare facilities, so that the system can grow to the point of continuing to supply professionals not only here, but to the rest of the world. In the meantime, with our country's fiscal constraints, we have to figure out, as it relates to healthcare and healthcare professionals, how to get more with less in the short term and how to simply get more in the long term. The answer must lie in a combination of regulatory reform, proper resource allocation, appropriate compensation, and relevant education. It's really about supply and demand and making policy choices that will benefit the Filipino people and not just vested interest groups. Thank you for participating in today's summit. The proper execution of many of your ideas will help address one of the country's most critical pain points. Good morning.
Thank you very much, Mr. Consing. Up next, from a true green Lasallian to probably the bluest Atenean, let's hear some welcome remarks from the President of the Ateneo de Manila University, Father Roberto Babiap of the Society of Jesus.
Distinguished guests, dear colleagues and friends, ladies and gentlemen. It is really a privilege and an honor to welcome you to Ateneo de Manila University for the 4th Annual Health Leadership Summit. I especially welcome Dr. Ted Herbosa, the Department of Health Secretary, Director Johanna Banzon of the Department of Health, our keynote speaker, Dr. Suwit, Senior Advisor of the Health Ministry of Thailand, and our other keynote speaker, and all the people who will sit and discuss in the distinguished panel. My gratitude to everyone who braved the rains, possible floods, and the traffic to be here in Katipunan in Ateneo. I would like to thank our event co-organizers, our friends at AC Health, led by the President and CEO, Mr. Paulo Borromeo. I also like to thank Ayala Corporation, led by President and CEO, Mr. Cesar Consing. Actually, I'm very good friends with Brother Bernie Oca of De La Salle. And in our last meal we had together, we said, well, for UAAP basketball, we are on the same side because we have a common foe this time. I would also like to thank the 4 schools, the deans of our 4 schools, Ateneo Law School, Graduate School of Business, the School of Government, and the School of Medicine and Public Health for also organizing this summit. First held in 2018, the Health Leadership Summit aimed to engage participants in a multi-sectoral discussion on the crucial pillars of the Universal Healthcare. Universal Healthcare Act was signed into law the following year, 2019. The landmark legislation prescribes healthcare system reforms, institutionalizing equitable, accessible, and cost-effective healthcare services for Filipinos. Every Filipino citizen, young and old, is expected to receive the services they need without financial hardship. That is 115.5 million Filipinos according to the latest World Bank data. At the 2019 United Nations General Assembly high-level meeting on universal healthcare, heads of states and governments reaffirmed their commitment to achieving universal healthcare coverage by 2030. But universal healthcare implementation is not only about having a well-oiled health system. There must be solid political and civic commitment. That means it can no longer be the business solely of the government's health department, but of the whole government, communities, businesses, academia, and civil society organizations. Strong collaboration and engagement among stakeholders are critical to ensuring that universal healthcare coverage is achieved. At Ateneo de Manila University, universal health and well-being is a key strategic area in our university strategic plan. It resonates with our vision of effecting societal transformation through education, formation, research, and social engagement. This annual summit is but an example of our interdisciplinary collaboration between law, business, government, and medicine. Sharing our experiences and insights allow us to forge the path ahead together. I hope this meeting will leave us with a renewed commitment to ensure that every Filipino will have a future of accessible and affordable healthcare. Our shared goals are possible if we remain focused, fully engaged, and work hand in hand. I thank you for your kind attention and wish you productive discussions. Magandang umaga at maraming salamat sa inyong lahat.
Thank you, Father Bobby, for your wise words. So I hope everyone's appetites have been whetted because we are about to hear a special message from one of our esteemed guests this morning. It is my honor and privilege to introduce you all to the newly appointed Secretary of the Department of Health, Dr. Teodoro Orbosa.
Allow me to recognize the presence of the President and CEO of Ayala Corporation, Mr. Cesar P. Consing, President. Also the President of Ateneo, Father Bobby Yap. The Vice President for Higher Education of Ateneo de Manila University, Dr. Maria Luz Vilches. To the AC Health President and CEO, Mr. Paulo Borromeo. The Dean of the Ateneo School of Law, Attorney Jose Maria Hofilena. The Dean of the Ateneo de Manila School of Medicine and Public Health, Dean Dodi Alfonso. PCP President, Dr. Jean Solante. The Dean of the Ateneo School of Government, Randy Tuaño. Department of Migrant Workers Undersecretary Hans Kakdak. My other colleagues in academe like Dr. Kenneth Hartigango, who's here with the Ateneo School of Government. The keynote speakers, Dr. Joanna Banson from the Department of Health, Dr. Suwit from Thailand, former Health Secretary Manolet Dairit, all the Ateneo students and De La Salle graduates here present. Good morning. I did not graduate from Ateneo nor De La Salle, but I have two daughters that graduated from Ateneo, but I'm proudly a Benedictine-educated San Beda graduate. And you all very well know that it was the Benedictines that helped St. Ignatius heal in Montserrat. And even for the young people here, even before there was an Ateneo-La Salle rivalry, because La Salle is a new school, there was the Ateneo and San Beda rivalry way back in the 50s, all to the early 60s. So we always take pride in the rivalries of the three schools. And my grandfather, Stanislao Herbosa, was very happy actually, because he had three batches of grandchildren. One batch was with De La Salle, the Herbosas in Green Hills. And then there were the Herboses in Bel Air who studied in Ateneo, and the Herboses in Santa Mesa who studied in San Beda. So during the NCAA before, he was always happy because any of those three schools usually became the champion. Another bit of story maybe for the students here. As I said, I'm not from Ateneo, but our family has a heirloom in the Ateneo here. So if you go to the Rizal Library, you will see the lamp or the gasera where Dr. Jose Rizal, my great-grand-uncle, kept the Mi Ultimo Adios. He gave it to my great-grandmother Lucia, his sister, and said in English, there is something in the lamp. It took 6 months before they discovered the Mi Ultimo Adios, rolled in a small piece of paper, written, which is now a very famous poem. And also I think here is the wicker chair, right? The wicker chair where the chair he sat on to write the Mi Ultimo Adios the night so you'll see it there. I always ask my daughters to go there to look at it. It's lent by the Herbosa clan. So we don't know who's going to inherit it, but I think it's going to stay in Ateneo forever in memory of Rizal, a famous Atenean. So I'm honored to join you today in this 4th Annual Health Leadership Summit 2023. My heartfelt gratitude to the organizers of the event, to AC Health, Ateneo School of Law, the Graduate School of Business, School of Government, and the School of Medicine and Public Health. You see, health leadership extends beyond administrative roles. It embodies the art of inspiring and guiding diverse teams towards a common goal: the well-being of every individual, irrespective of their socio-economic background, in our pursuit of universal health coverage, where quality healthcare is accessible and affordable for all. Leadership becomes a beacon that illuminates the path forward. Leaders within health systems must exhibit unwavering commitment to fostering collaboration and innovation. They must navigate through complexities, foster interdisciplinary cooperation, and harness the potential of technology to bridge gaps in the healthcare delivery system. A true health leader empowers frontline workers, acknowledges their invaluable contribution, and ensures that their well-being, for they are the lifeline of any healthcare system. Furthermore, health leadership involves advocating for equitable distribution of resources, ensuring that vulnerable populations are not left behind by fostering a culture of empathy and inclusivity. Health workers and health leaders can help break down the barriers that impede access to care. This proactive stance not only strengthens health systems, but also echoes the principles of social justice and underpins universal health coverage. As we envision a world where preventable diseases are minimized, where maternal and child health is prioritized, and where no one faces financial ruin due to medical expenses, health leadership takes center stage. Effective leadership drives policy reforms, engages with stakeholders, and promotes transparent governance. It paves the way for sustainable financing and the mechanisms that will make UHC a reality rather than a distant dream. The management of health in this country is multifaceted and complex. It entails several systems moving independently of each other, built together to deliver significant health outcomes. The human resource for health, or HRH, is one of the significant components of the health system. The knowledge, skills, and motivation relative to the organization and delivery of the health services directly affects the achievement of better health outcomes for a Filipino. Before I became health secretary, I was a clinician and an academician. And I always thought that the health system is not an infrastructure, it is a service. And as a service, it is actually dependent on the people that provide that service. The recent pandemic has tested the world's healthcare systems. In the Philippines, the health workforce was stretched to their limits to deal with preventing, treating, testing, and rehabilitating people who were affected by the disease and the complications brought about by COVID-19. The untiring dedication of healthcare workers has been remarkable during this difficult moment in our history. However, the unrelenting demands in healthcare has placed the country's health system in a spotlight, exposing vulnerability and fragility to capacitate, protect, and ensure welfare of this essential human capital, the people. The collective experience taught us hard lessons as it unveiled strengths and opportunities in bringing out the potential of the Philippine health workforce. Indeed, the Philippines is blessed to have a formidable asset, human resources for health. This untapped resource can boost the Filipino spirit with a global recognition in the provision of world-class healthcare services. As such, we must ensure that Filipino health resources are well-trained, highly motivated, and valued to contribute to the country's well-being and therefore be agents of building this nation to be great again. Under this administration, the Department of Health spearheads an 8-point action agenda. Embedded within it is the recognition that health is multifaceted and multifactorial. Based in psychosocial and sociocultural determinants of health, there needs to be a multi-pronged approach to targeting health outcomes. We can appreciate that the provision of health services only comprises about 20% in addressing health outcomes. As such, the principles under the Universal Healthcare Law resonate with the implementing guidelines through this 8-point action agenda insofar as the whole of society and whole of government approach is required to attain universal health care. Emphasizing the 7th action item in this agenda, kapakanan at karapatan ng healthcare workers, we will strive to provide decent working conditions for our healthcare workers as well as encourage retention in the country. This action agenda is essentially enshrined in the National Human Resources for Health Master Plan 2020 to 2040, which primarily aims to contribute to the attainment of universal health care. Ultimately, what we wanted to achieve is a competent, satisfied, and motivated Filipino healthcare worker. We wanted to encourage sustainable reforms for the health sector in collaboration with the private sector, business community, and the academe. Towards this end, we aim to forge engagements with both the national and local government implementers as well as stakeholders for creative and flexible solutions to issues that the Filipino health human resources are confronted with. Several health sector reforms had been initiated in the past. Former Atenean and Secretary of Health, Quasi Romualdez, Health Sector Reform Agenda from 1999 to 2004. The Formula 1 for Health in 2005 to 2009, to Health Financing Strategy in 2010 to 2016, to Kalusugang Pangkalahatan of the former Secretary Ike Ona in 2010 to 2015, and for the All for Health Towards Health for All in 2016 to 2017, until the Formula 1 Plus for 2018, the DOH has been steadfast in expanding services to the Filipinos. These reforms have brought significant human resources development, which subsequently improved the success of Filipinos to a healthcare worker, especially in the underserved areas. This has also encouraged our health human resources to actually serve in high-risk and geographically isolated and disadvantaged areas of the country, which is driven by competition and packages and incentives. As the Universal Healthcare Law paved the way for the Philippines to embark on a meaningful health development initiative, this 8-point action agenda is pursued by the Department of Health to fulfill the mandate to lead in the health sector in the development and through the issuance of national policies and plans, capacity building, and health regulation, among others. In order for the Philippines to attain universal health care, both primary and specialized health care, or the whole health system, must be coordinated in such a manner that a network based for the patient that will be easy to navigate and access health services whichever and wherever they need them. The primary care facility shall serve as the first point of contact of patients' families and communities with the healthcare system to access basic and comprehensive primary care. If a higher level of care is needed, they must be referred to the other levels of hospitals or standalone ancillary specialized facilities within the healthcare provider network. Level 2 and Level 3 hospitals will provide the intensive care services and specialty services. And just recently, the President signed the law for the regionalized specialty hospitals in the different DOH hospitals. From the standpoint of the Department of Health's National Health Workforce Support System, several national programs have been implemented to augment the health workforce in both the primary care provider network and the healthcare provider networks. To name a few, we had the program of Secretary Flavier, the Doctors to the Barrios program, which continues to this day, the Health Human Resources Deployment Program, the primary care provider network, while there's the post-residency deployment as well, which is a Specialista para sa Bayan program of the healthcare provider networks. Ultimately, the heart of universal healthcare is through the human resources for health. Primary care happens when we take care of our workforce. Through them, initial contact, accessible, continuous, comprehensive, and coordinated care are accessible at the time of need. At this juncture, we would like to drive home the message that the Department of Health, in this overarching 8-point action agenda for health sector, is one player in making the Philippine health system resilient. The essential cogs in the wheels come from the private sector and the academe, who are valuable nation builders and catalysts in the health sector development. Likewise, the Department of Health acknowledges these partners and health system actors to make UHC a reality in this country. The synergism of these sectors complements the endeavor of our nation. The Department of Health is intentional to open its doors to active and meaningful engagement of these various development sectors of our society. We take a special emphasis on the involvement of the youth in advancing universal health care in the country. Allow me to borrow words from the timeless quotation of our national hero, Dr. Jose Rizal, "The youth is the hope of our future." Today, youth engagement is crucial in the backdrop of rapid technological advancements. The young people can provide the fresh ideas and innovative solutions to old wicked problems of our society. They can lend their time to participate in public health advocacy campaigns, research endeavors, and community immersion programs for health, among others. Their voice is essential to be heard, even for the most experienced leaders in the health sector. They should be part of the health development discourse for them to fully embrace responsible citizenship and fully capable partners in nation building. Lastly, I would like to close this message with a lighter note that the UHC dream is a collective endeavor, a bayanihan of its own, something that we can only be part of as the journey towards a sustainable future. For a healthy Pilipinas, kasama tayong lahat sa pagpaalaga at ng ating kalusugan dahil bawat buhay ay mahalaga. Maraming salamat po at mabuhay po kayong lahat. Thank you.
Thank you very much to Secretary Ted Herbosa. Indeed, the topics of health leadership and human resources for health are such complex matters to navigate, but of course, with the collaboration, innovation, and dedication of our healthcare workers, which as Secretary Herbosa said, forms the heart of our healthcare system, then we are able to take strides towards a healthy Pilipinas and UHC for all.
Exactly. And it's amazing that all of our three initial speakers actually share the same overarching message and goal of an interdisciplinary approach towards our HRH and UHC overall. And it's quite amazing also to know that leaders from government, from the private sector, and from the academe all share in the goal of ensuring our healthcare workforce is taken care of. So before we move on to the next part of our program, I want to remind everyone that if you want to talk about HLS online, you can talk about it on Facebook, on LinkedIn, and make sure to tag us at AC Health and the Ateneo de Manila on your socials. On Facebook and LinkedIn, we don't have an Instagram and TikTok just yet, but feel free to talk about us there. And don't forget to use the hashtag HLS 2023. So up next, we'll be having the first of our two keynote speakers. She is the current Director of Health Human Resource Development Bureau of the Department of Health and a former faculty member and administrator of the Ateneo Graduate School of Business. She received her master's in science in international health from Karolinska Institutet in Sweden and her diploma in tropical medicine and public health from the Humboldt University in Germany. Here to talk about human resources for health through the lens of universal healthcare in the Philippines is none other than Director Johanna Banzon.
Salamat, Rafa, at magandang umaga po sa lahat. I'd like to read the acknowledgements so that we're on the right foot. Okay. Magandang umaga po, Boss, DOH Secretary Ted Herbosa, former Secretary Manolet Dairit, former Undersecretary Mario Villaverde, Father Bobby, Ateneo de Manila President and brother of my sister and good friend Marifea, Dr. Vilches, Dr. Suwit, and Dr. Kanang. I'm struggling here. Our expert panelists and moderator, Dean Dodi Alfonso, Undersecretary Hans Kakdak, Dr. Kenneth Hartigan-Go, Dr. Rosel Tolentino, Mrs. Gaget Bengzon, and Dr. Jean Solante, Mr. Cesar Consing, and Mr. Albert de la Razbal, Paulo Borromeo, good morning, together with the rest of the AC Health leadership team, and the deans, of course, of the APS, which I was a member of before, Dean Joey Hofilenia, Dean Randy Tuanyo, Dean Jet Magsaysay, health industry partners, friends from government agencies, guests, and students. I see in the crowd a lot of my former bosses and of course my current boss, former colleagues and current colleagues from the Department of Health. I actually see some from Bohol, from the Department of Health, no, who joined us, and some mentors, my mentors and students. So welcome and good morning. I was invited and tasked to set the tenor for the discussion this morning, but those who came before me already set that tone. And but I was given the instruction to set the tone in 10 to 15 slides and under 20 minutes. So what to talk about and where to start. So I think it's important that we level off. Binag-usapan na po natin kanina ang universal healthcare. Secretary of Health has given us a wonderful orientation, but let's just level off. Okay. So when we talk of UHE, there are three main features. Students, if you have to talk about UHE or remember three things about UHE, these are the three things. The first is the organization of the health system into healthcare provider networks. HCPN. That's a keyword. At na-explain na ni SOH kanina, no? HCPN is composed of at least a PCPN or primary care provider network that has a barangay health station and a primary care facility. If you were listening to the Secretary of Health, he said what? Primary care facilities are the navigators of care in UHC. So mahalaga na the PCPN is in the HCPNs. So all of the nationwide, we will have HCPNs to organize healthcare provision. The second, we have classified all health services into population-based and individual-based health services. So that's the second thing you should remember. Population-based care packages versus individual care packages. And the third thing you should remember is the simplification of the health financing mechanism, where individual health care is mostly funded by premiums of the national health insurance, and the population-based is tax-based financing. So are we good there? I will not talk anymore about UHC. So klaro yun. Sige. So UHC by itself is very interesting, but UHC and HRH, what are the implications of HRH ngayon na nasa UHC? So what challenges, what questions do we need to answer? Una sa lahat, UHC na tayo ngayon. Teka lang, before I forget, UHC is not a program. Please remember, it's not a program, it's an aspiration, it's the way we will move on in the health sector henceforth. So that's clear, huh? That's not a program, it's a dream. It's the way we will deliver healthcare. Okay, now that's said. Ano ang challenges? What are the implications? UHC na tayo ngayon in the Philippines, but the Philippines is an archipelago. And we have a certain demographic profile. We have 111, as of December 22, our population is 111 million. We have a risk profile na ganito, tulad ngayon, binabagyo tayo or inuulan. Anong implications nun? What composition of the Philippine health workforce will future-proof the system? What does our HRH look like now, and what do we need to create to future-proof the health system, right? Next question. What are the key and crucial cadres that have to be in place to have UHC and have UHC work for us? What standards are in place? And when we talk about standards, this is not just staffing standards we're talking about. What are the standards for production of HRH? What are the standards for competencies? Ano bang kailangan natin? What are the standards for work conditions of the health workforce? Okay? And what interventions are out there that's being done for our health workers? Okay, so these challenges confront us in the time of UHC. But to go back to the basic, sino ba ang health worker? Who is the health worker? Sabi ng WHO, a health worker is anybody doing work that enhances health, improves health. So, you will have usual suspects, doctors, dentists, nurses, midwives, pharmacists, medtechs, right? But following that definition, also manong janitor in the hospital, security guard, ambulance driver, traditional hilot, right? So as in DOH, in HHRDB, we said, let's have a classification that will simplify things for us. So in this classification, we realized that there are two main categories patterned after the UHC. So we have health workers that, and they are called health service providers, we just call them health service providers, whose intention is to improve individual health. And the second category are public health scientists or practitioners whose aim is to enhance population health. Okay, under the health service providers, we have, again, the usual suspects, the healthcare professionals. Ito yung mga doktor, the one we spoke of earlier. If you need a guide, these are the healthcare providers who are licensed by PRC. Okay? There's 13 of them. Mula doctor, dentist, X-ray technician, OT, PT, dyan papasok. Okay? But besides our healthcare professionals who are licensed, there are people who give care who are either non-professionals or non-health workers. Who we spoke of, si driver, si security guard, priests. Diba? And this is the second category, subcategory, under the health service providers whose intention is to improve individual health. And we have a lot. We have massage therapists, we have traditional healers dito. Under the second category, we have public health scientists and practitioners. And this group of health workers really create new knowledge or have a subject matter expertise that improves our programs, our interventions. Ito yung pumapasok si epidemiologists, biostatisticians, geneticists, bioethicists. The fourth are public health system managers and administrators, and a lot of us belong here. And this group is neglected. When we talk about HRH, immediately we say, nurse, going abroad. But that's not all our HRH. We have this fourth subcategory, and these people run the system. And we don't know how many they are, how they are trained, what schools are there, how many we need. So we devised this tool, this framework, to help us, especially in HHRDB, understand our health workers more. Okay. So for example, in this first category, we know that ang migration affects this group, but it doesn't affect 2.1 or 2.B. Okay, so ang concerns would be, and this is just a sample, migration is affecting this group. Staffing standards affect this group. Sa second group, the need to professionalize, the need to maximize the contribution to UHC, for example. The other day, I sit in the, this is really awkward, I sit in the board for embalmers to prepare the exam questions, trying to professionalize. That's an HIH issue. So I asked doon sa group, how many embalmers do we need? Do standards exist? Hindi, no? We always talk about that first line. Sorry. Oh, it's back? Okay. The other group, we would have public health scientists. We don't even know how many we have. So ang issue nun, enumeration, or let's inventory them. How many are there in CHD 7? In region, in BARM, how many do we have? How many do we need? Do we have plantilla for them? Recognizing them as scientists. Meron bang plantilla for bioethicists, for example? Diba? And similarly, the public health system managers and administrators have this problem of enumeration. My background, my bachelor's is nursing. I took up epidemiology. I worked in Ateneo for the best part of my life, for almost 15 years as a teacher, researcher, but I'm doing HR work now. From an HR point of view, paano ako bibilangin? If I have to do an inventory, If I have to complete 100 people in NCR for say HRH practitioners, saan ako ibibilang? Doon ba o sa nurse? So these things have to be well thought out. So certain issues confront certain clusters of health workers, but there are 3 issues that cut across these 4 clusters. The first one is adequacy and availability. Sapat ba ang ating health workers sa pangangailangan ng Pilipinas, sa pangangailangan ng UHC? Do we even have standards? So sapat ba ang masahista, for example, I mean for lack of a better example, just to illustrate, or psychiatrists, sapat ba ang well, I remember at the start of the pandemic, one of the first people who died was a pediatric surgeon, transplant surgeon. You remember, sir? Remember, there was one of the first patients who died was a pediatric transplant surgeon who went home from training from the States as a specialist, came back. He was, I believe, the only one of the very few. Kung namatay na siya, wala na tayo. It's very frightening, no? So sa time ng UHC, just because primary healthcare underpins the attainment of UHC doesn't mean, as HR, hindi natin pag-iisipan yung specialized care. Okay, so adequacy and availability cuts across all categories. So health policy experts, health planning, health financing experts, ilan yung kailangan natin, ilan yung papaaralin natin, ilan yung de-develop natin. Second cost-cutting issue would be competence and commitment. So commitment is a big thing for us, and also competence. Are health workers able to dispense of services that are needed during UHC? And thirdly, decent work conditions, especially decent work conditions. Dr. Herbosa spoke of the 8-point agenda, and the 7th agenda is karapatan at kapakanan ng health workers. We believe that this is very fundamental to the discussion on HRH. The health workers are the backbone of our health system, and they contribute greatly so that all of us can enjoy the right to health for all. But they should also be protected, and their rights protected so that they can also enjoy good working conditions, decent working conditions, so that their health is also assured, so they can enjoy the right to health. Okay, so I'm a little passionate about this. So when we talk about health worker and the Philippine health workforce, there is a tool we use. And this is the HLMA, Health Labor Market Analysis, or Health Labor Market Framework. And Mr. Consing said very succinctly, very clearly in his talk kanina, it's an issue of supply and demand. So this tool allows us to trace, and this depicts the movement of the health worker from the time the health worker is produced. Let's just use that word, okay? The health worker is trained and produced and qualified, and the health worker participates in the health labor market, and sometimes exits, sometimes comes back. So this is the tool that we use. Galing po ito sa WHO. But in DOH, we devised a similar tool that's laymanized. And we call this, because we are high-tech, the timba. So we have a timba. This is essentially based under the HLMA. And this timba represents all that we need to produce in terms of HRH to meet our needs. Our goal is to fill the timba. based on our population of 111 million, sabihin na natin, estimate, and based on the SDG standard of 44.5 HRH per 10,000, actually it's 4.5 per 1,000. Kaya lang, sobrang konti tayo, so 44.5 per 10,000. We need 496,497 doctors, nurses, and midwives. 14.3 doctors per 10,000, 27.8 nurses per 10,000, and 2.8 midwives. Okay, again, this is just on the 3, yung 1.1 natin na cluster. And don't get so focused on the numbers, okay? Just look at the story, the narrative that we're trying to share here. So, paano natin pupunuin ng timba? We have the health labor market. Kanina sa HLMA, yung production. So we have a faucet. This is the pipeline. This is where the SUCs, state universities and colleges, these are the higher, the health education institutions. They produce for us, the RHRH, no? And in the past 10 years, this was from 2011. And I use this because this is the data that I have that's claro. So we had 13,829 enrollees to medicine, 177,252 enrollees to nursing at the start of the school year, and 11,767 enrollees to midwifery. But may tulo ang ating pipeline. There is a leak. And 74% of students who enrolled in medicine did not graduate. 86% in nursing did not continue, and 64% in midwifery did not continue, which means ang nag-graduate sa medicine, naging MD, 26%. Sa nursing, 14%. And sa midwifery, 36%. Kabaliktaran lang ng dropout, ng attrition. Right? That's our attrition. And among those who graduated, not all of them were qualified. Not all of them were licensed. So out of the 26% ng medicine, 94% passed the exams, licensure. And 49% of the nurses passed, and midwives, 60% of the midwives passed. And currently, so ito current na to na data from PRC, we have active, registered, licensed health work doctors, nurses, and midwives. 89,000 as of December 2023. No, this is March 2023. This is very recent data. 89,533. Nurses, 475,995. And midwives, 65,473. So anong conclusion? Yay! 496 ang kailangan natin eh. So are we good? No, we're not good. Because those that are practicing in the health facility, in the health sector, are 282,958. Asan yung iba? May tulo yung timba. There is leakage. Was that wrong? Oh, I'm sorry. Tulo is not okay. I'm sorry, there's a leak in the timba. I just suddenly remember that. There is a leak in our timba that has to be fixed. Yeah. So we have about, dapat 631. Sorry about that. Not so sensitive. So there, may tagas is the better word, sir. May tagas. There's a leak. So, which means we have, and the tagas is people living. Ito na pag-usapan kanina, no? people are migrating, and we don't even know whether this represents part of the 631. No, some of them would be unemployed, some will be going to another endeavor, which is not health, and other industries, BPO, for example, aviation. We had a very good discussion around this. So what do we need to do? Which means there is a gap of 213,000 if we were to follow the standard that we have here. What do we need to do? We need to fix our tagas. We need to manage this so we can fill the gap, fill the timba, and ensure that we have enough HRH to meet demands. Now, there is an ongoing discussion with the private sector, with the HRH network, na on attrition. So, all these tagas is called attrition. Attrition, attrition, attrition. And the mindset is, ay, nakakalungkot, nakakainis, attrition. But I think we can also adopt a positive mindset. Now, instead of looking at it as loss, as weakness, as reduced strength, we can look at this as opportunities. So, enrolled but not graduated, graduated but not licensed, licensed but not in the health facility or not in the health sector, or migrated. Instead of looking at this as attrition, how about looking at this as opportunities for us? For example, possibilities of new cadres. There are people who enter, say, nursing or medicine, first year, drop out. What do we do for them? What do we do about them? Baka pwedeng local health promotion workers, just think about these possibilities, or local health administrative assistants. And I remember, SEC, we spoke, the RDU Mang in Davao, and there were 6 RHUs that just experimented, and they just hired admin assistants in the RHU. Usually kasi si midwife yun or si nurse nag-administrative work. And you know what they noticed? Client satisfaction improved, performance improved. Wala pa sa health outcomes yung evaluation, but just adding an admin assistant in the health center improved the services immensely. So that's something that we can think about. Currently, we have between DOH and CHED, and this was recently signed also in partnership with PISAC, yung Joint Administrative Order 2023-001, which provides for those who have not been licensed for nurses to actually have work in health facilities that are willing and able to hire them while they are reviewing for nursing boards. So nakakatulog sila, augment ng health workers in the health facility, but they're also being helped to prepare to be licensed. So these possibilities. And also, the work with the private health sector. Parang a lot of our HRH is needed now in the industry, in BPO, for example. And instead of looking at this as attrition, how about we look at it as possible partnerships for big data analytics, telemedicine, and telediagnostics. Okay, I have 5 minutes left. Okay, so now all these strategies and many more are in our National HRH Master Plan. So we actually have a master plan, and this is where all these strategies are spelled out. Just one of the strategies for HRH migration, the idea is to produce through scholarships and reorientation of the curriculum, and have a pool of HRH who can choose, who will choose to either stay in the country or leave if they want. But if they choose to stay, we should be able to provide for them a green pasture, a good working condition, so that if they do decide to migrate, it's not because wala silang choice. For migration, if they choose to migrate, we should be able to support them. They are still our workers. Their rights have to be protected. We subscribe to ethical recruitment practices and government-to-government bilateral agreements instead of agencies that's coming and poaching and not being systematic about it. Okay, so now currently we have an HRH network, and the HRH network is a group of representatives from government agencies, from the private sector, and we come together to talk about entry, workforce, and re-entry. This is how it is, but our proposal is really to create a fourth group on HRH data and information, which we hope will address a core challenge in data, in HRH management. It's a lack of accurate and timely data. Okay, I have 2 minutes more, and I'm nearing to the end. Okay, so this is the work that we're doing in the DOH. Remember at the start we said UHC poses challenges to HRH, and this is what we're doing now. We're trying to, this work is ongoing, to create or consolidate the standards that are here for the time of UHC. Ilan ba ang healthcare providers, category 1? Ilan ba ang public health workers? What standards are there for their production, adequacy, competence, and decent work? And what is the current profile? What interventions are currently being done by the whole of society to ensure that we have enough, we have good quality HRH, and that they are protected and their rights are protected and championed. So last slide, our call to action is that we really cannot do this alone. It's clear that UHC is led by DOH and PhilHealth, but we cannot do this alone. We have to work together. Whole of society collaboration is needed on HRH welfare, protection, and career development, data and information sharing, and proactive conversion of attrition to gains. Usap tayo. There's a lot of possibility there. And just to say that all of us have roles to play. We are working with DMW, with DFA, with DOLE, and with the private sector. Let's work together some more and make sure that we play our part in making UHC a reality. Maraming salamat po. 1 minute left. Thank you.
Thank you so much, Director Joe. You know, it felt like I was in CTC 201 just listening to another HS 201 class or Sci-10 after listening to everything that Director Joe had to say. And it's quite interesting that she mentioned that we do forget a lot about our public health practitioners and the non-professional healthcare providers when we talk about HRH. But it's very hopeful to know that the DOH has that very extensive 20-year plan addressed and managing our HRH towards the dreams of UHC.
Yes, thank you very much again to Dr. Banzon. Moving on our next keynote speaker is nothing less than a giant on the international stage when it comes to public health. He is currently a senior advisor at the Ministry of Public Health of Thailand, and he is the former vice chair of the WHO Executive Board, former chair of the Program Coordinating Board of the UNAIDS, and the former president of the Steering Committee of the Asia-Pacific Alliance on HRH. In addition, he was also recently awarded by the WHO as one of its heroes for public health. To share perspectives on HRH management strategies in developing countries, let's give a warm round of applause to our next speaker, Dr. Suwit.
Excellencies, the two presidents, former health secretary, friends and colleagues. before I start, please don't forget hashtag HLS 2023. Let me tell you, I don't have any social media, so I don't know what they mean by hashtag. If you look at the program, my time is already out. But my colleagues here, his father-in-law, her father-in-law, was my mentor when I was young on generic drug. She has already mentioned everything important point, particularly the last slide, the slide on the, the flow and the leak. Very interesting. Now, I'm going to be short on how you achieve SAFE, HRH and USC. I'll tell you more. What does it mean by SAFE? Next slide, please. Oh, I have to do it myself, right? Good. Did I do anything wrong? Okay. First point is that when we say health, we are not doing HRH or USC just for HRH or USC, but we do it for health. And health means well-being. Health is not just no disease and no infirmity. When health is put into the hand of health professional, we tend to say that, we tend to feel that it means no disease and no infirmity. It means medicine, it means hospital, which is damn wrong. It means well-being, social, mental and physical well-being. That's the definition. And it depends not only on healthcare system where we belong to, it depends on ourselves. 80% of even the illness not belong to healthcare system, it belong to people. And the environment, politics, physical, mental, social, germs, that contribute to health. So we must be careful not to equate USC mean well-being. It's just part of it. Next, please. And this is healthcare system. It starts on the left side. You start by producing knowledge. And from the knowledge, you use the knowledge to produce human resource. You use the knowledge to develop and produce medicine, essential one. Medical device, facilities. And then you organize them into public-private facilities. And then they provide a service which contribute only to 20% of disease and infirmity, not mentioning the overall well-being. So we are so small. Contribution to well-being. We are not a big contributor. And all these three components need good governance, need a safe financing system in order to maintain it. Now, what is USC? Next, please. When you talk about USC, you usually talk about universal access to essential services, right? Without financial barrier, right? That's USC. And HRH, health workforce, health manpower, whatever what you want to call. When you talk to the UN people, they usually start with some term. Health manpower initially. And when people get used to the term, no more important, they move to a new term, health workforce, the same thing. And then health workforce become bored, they move to human resource for health. Soon they'll have new term, but everything the same. That's how the UN people do their business, earn their living. Okay? Next, please. You need self, HRH and USC. Sustainable. What does it mean? It means the country can afford, the government can afford, and the people can afford. If you spend 7% of your, if you spend 6% of your GDP on health, does it mean that your country can afford? Or as compared to the US, 17% of their economy is spent on health expense. In Thailand, less than 6, Philippines 6. You have to determine how much your country can afford. How about the government? How much of the percentage of the government expense should be on health? In your case, 7%. In our case, 15%. Is it sustainable for Thailand, 15%? Is it sustainable for Philippines? It's your decision. And how much we want our people to pay for health. In Philippines, nearly 50% out of pocket. In Thailand, 12%. And what do you mean by universal health coverage without financial barrier? You need S, sustainability. And you need adequate, enough to cover all essential health services, enough to protect people from catastrophic health expenditure, and to protect people from falling into poverty because of illness. How much is enough? You have to determine yourself. Do you think that 50% of health expense out of pocket is enough? I don't know. So this is the second term. Fair. The rich pay more, the poor pay less. The people with good health pay more. People with ill health pay less. This is fair. Equitable distribution of human resource. This is fair. Okay? Efficient. I just talked to Kenneth about health technology assessment. You need value-based health care. Don't be duped by the industry, the pharmaceutical industry. Value-based health care has 5 principles. First, focus on prevention and promotion, because that's most valuable, most efficient. Second, payment by bundle payment, not fee schedule. The bundle payment, capitation, DRG, those are the most cost-effective payment. Third, whenever you introduce new medicine, new technology, you need health technology assessment to ensure that they are cost-effective. Okay? Fourth, procurement, central procurement, bulk purchasing, strategic procurement. And the last one, you need real good health data to manage the system. Unless you have all 5, you cannot have value-based healthcare. The same for HRH. And efficient, as I said, value-based. Next, please. And these are the measures for self-HRH. I call it the 5 E's. In Thailand, we never have problem like what Dr. Bengson just mentioned. Attrition rate is near 0 for all creditors. Most of them are licensed. And we have near 0 out migration. With one very, very effective measures to prevent ex-migration. We don't teach them good English. Do you think that is effective? Yeah. I can tell you, Thai doctor who can speak English like me is, I don't say exceptional, but most of them cannot pass the English test to go abroad. In my class of 70 people, 70 of them passed the medical part of TOEFL, of ECFMG, but only 7 of them, including me, passed the English test. So if you want to solve it effectively, don't teach them good English. The Japanese, the German, try to set up recruitment, mechanism institute in Thailand to recruit Thai nurses. They all fail because we don't teach good English. But actually, that is a painful joke, but but it's true. You see, you have first E, education. If you go to the rural hospital, or rural hospital, provincial hospital in Thailand, and district hospital, and you call in all the nurses, you ask one by one, where are you from? I'm from here. Where are you from? I'm from here. They all were born and live in that area. Rural recruitment, local training, and hometown placement. This has been going on for several decades. And transformative education, primary care based, community based, that is most important. Engineer, technology, and environment. You need to do more research. Like what Benson just mentioned, she has all the data, which is important. Without data, you cannot measure. If you cannot measure, you cannot solve. Okay? Economic measures. We have compulsory contract. Every medical doctor get into medical school. Most of our medical schools are public. We have few private medical schools. Like me, when I get into medical school, I have to sign a contract. Work for 3 years for the government. Or else I face a $12,000 fine. Okay? And most doctors, after 2-3 years, they leave. They leave the rural hospital. And they went to the city to study specialization. Those who stay on are not that clever. So we judge how good, how clever a doctor in Thailand is by asking them how many years you work for the government. Like me, 8 years. Not very clever. Some of my colleagues, even 12 years. Some of them, I'll show you, more than 30. They retire there. Those are most stupid. Okay? Appropriate incentive, not too high. We are giving our doctor too much money. Nurses as well. Imagine a new medical graduate in Thailand. If he or she work in a remote rural hospital, he or she can earn in a month. I have 5 minutes left. He or she can earn in a month more than the monthly salary of a health minister. That's true. We have given them too high, but they still complain. People never have enough. They still complain that they work too hard. Okay? Enforcement. In some countries, conditional licensing. If you don't work for the government for certain years, you don't get license. Indonesia used to do that. In Thailand, we have that as well. If you don't work 1 year for the government, you cannot go into specialty training. If you want to go into specialty training, at least a year. Empowerment, I think the last one is most important. Recognize them. The oldest medical school in Thailand, most prestigious, like Ateneo, give annual outstanding rural medical doctor award. And it's all publicized all over the country. And it inspires medical students. That's what I want to be. Oldest, most prestigious medical school, not by the Ministry of Health, but by the medical school themselves. And that doctor will be invited to give keynote, deliver keynote in the medical school. The money is so small, but the image is huge. Spiritual advocacy, role model. Next slide, please. These are the role models. See how many years they work at the Thai-Myanmar border. At the border, all of them receive in a month much more than the Minister of Health. I can guarantee you. From only the public money, no private money, no private practice. They even get a monthly $300. I call the lazy allowance for them not to practice privately. We allow dual practice in Thailand. If you don't practice privately, you get $300 a month. Lazy money. Okay? You see? One of them, the right lower one, he even crossed the border to work on the Myanmar side. Built 3 health centers by his own money. His hospital is always in red. And when he's in red, he just put on social media, oh, I'm $40 million in debt now. Within a few weeks, he become black. His account, no more red. Money pouring, lots of money. These are the role model. And for me, as an old doctor, spirit of human resource is the most essential component for the success of universal health coverage, not the money. More money you have, more fighting for money. More spirit, you have more health. Next, please. But all of this has to be realistic with this trend. Particularly technology disruption is very, very scary. All the new medicine that end with NIP and MAP, monoclonal antibody, very expensive. All the technology, robotic, nanotechnology, everything very expensive. And increase the demand. If the patient came in with back pain and doctor prescribed MRI, you increase the demand. The shortage of health professionals can be solved by increasing supply or reducing the demand. Technology increase the demand. Self-care will reduce the demand. Telemedicine can help reduce the demand. So you can do both, increase supply, reduce the demand, and promote health equity with rural recruitment, local training, hometown placement, solve health equity in both equity in education and equity in health. Next, please. These are biggest role model for Philippines. Equity. Next, please. This is the biggest role model for Thailand. Put self-interest as second, public interest as first. Thank you so much.
Thank you very much for that masterful talk, Dr. Suwit. And thank you for that reminder to put public interest first and self-interest second. Okay, so again, I think Dr. Suwit's lecture just reinforces the call earlier that given all of these challenges to universal healthcare and to HRH, all of us from the private sector, public sector, the academy really have to work together to ensure safe, adequate, fair, and efficient healthcare for all.
So after a series of very thought-provoking discussions, I believe that everyone is feeling a bit hungry. So we'll take a 10-minute break and you may proceed to the Leong Hall lobby for snacks. So we have sandwiches, dirty ice cream, and taho. While you're outside, don't forget to take pictures by the photo wall, and as Dr. Suwit said, don't forget to use the hashtag HLS2023.
Yes, while everyone's having their snacks, may we call in front our speakers this morning, Mr. Consing, Dean Joey Hofilenia, Father Bobby Yap, Secretary Ted Herbosa, Director Joe, Dr. Suwit and Dr. Kanang, and Mr. Paulo Borromeo for a quick photo opportunity.
So we'll see you back here in 10 minutes. Thank you.
Again, may we call in front our speakers this morning, Father Bobby Yap, Mr. Bong Consing, Dean Joey Hofilenia, Secretary Ted Herbosa, Director Joe Banzon, Dr. Suwit, and Dr. Kanang for a quick photo opportunity. Morning again, everyone. We hope you were able to grab a sandwich, taho, ice cream, or whatever it is that you wanted outside. If you weren't able to grab snacks, don't worry, they'll still be available after our program. So, I hope you're ready for the next segment, which is actually a very exciting segment. We have a number of expert panelists who are looking forward to sharing their insights and perspectives on HRH based on their wealth of knowledge and experience.
So before we begin the expert panel discussion, allow me to introduce our moderator. He is the current president of the Philippine College of Physicians and a member of the Healthway Philippines Inc. Medical Advisory Council. He is a renowned infectious disease specialist and a public health advocate. Let us greet with a warm round of applause our moderator for the expert panel discussion, Dr. Jean Solante.
Yeah, thank you, Rafa and Marian. First of all, we would like to welcome everyone for this segment, the expert panel discussion on HRH initiatives in the light of the universal health care. So we have here 5 distinguished experts in their own field. So I'll be introducing them one by one, and they will be occupying respective seats here in front. And then after that, each of the panelists will be giving their talk, 7 minutes with perspective on the perspective and insights of HRH in UHC. So the first expert is, we have Dean Dodi Alfonso from the Ateneo School of Medicine and Public Health. Welcome, Dodi. Then next we have Undersecretary Hans Leo Kakdak from the Department of Migrant Workers. And then we have third, the Dr. Kenneth Hartigan-Go from the Ateneo School of Government. And then next we have Dr. Rosel Tolentino, the City Health Officer of San Jose del Monte, Bulacan. And last but not the least, we have Mrs. Margaret Bengzon, Group COO of Healthway Qualified Network. Okay, so before we begin, allow me to discuss the mechanics of this expert panel discussion. Our 5 panelists will be sharing their thoughts and perspective of the topic, and each panelist will be given 7 minutes. Okay, so 7 minutes to share your talk, your perspective, and this will be followed by a 5-minute interactive discussion with other panelists, on the same topic, to be, of course, facilitated by me. And after all the panelists have spoken and all the topics have been tackled, we will have an open forum to accommodate few questions from our audience. So without further ado, let us begin with our first expert panelist, who will be talking about the training, education of healthcare professionals' perspective. He is a renowned hepatopancreatobiliary surgeon and the current dean of the Ateneo School of Medicine and Public Health. Kindly welcome Dean Zenon Dodi Alfonso.
Thank you, Gene. I think I misunderstood. I thought I'll have 20 minutes. 7 minutes, oh my. Okay, let's hold on to your seats. I'll go very fast. Okay. I don't intend to define health because it was already defined. I'm warning everyone. If you feel healthy, you may not be. Because it's not simply a feeling of freedom from disease or infirmity. WHO says that up to 55%, oops, is it coming up? 55% of health outcomes is not due to medical factors. Having more hospitals, the top of the line experts, etc., solves only half of the problem. Outcomes, health outcomes, there are other, such as the SDOH or SDH in short, the social determinants of health. And it has been said all along this morning. It has made my presentation very easy. Political decision. I just came from Kiamba last week of January, 7 days. All surgical, major operations for tumors, 100%. We did about 300 major operations for 6 coastal towns of Sarangani. 6. Only 5 came. 1 was not allowed to enter because of political affiliation. Only 4 or only 5 of the 6 coastal towns were allowed. So we were able to help out surgically the 5, but not the last one. It was a political decision. So it doesn't seem to work. Social, cultural, religious factors other than medical factors, this create the inequity. It's a wicked problem. And because it's wicked, we need a lot of time, generational in solution, and it's not simple. The solution is not simple, and the approach must be systemic, not how we do things. Next, please. But somewhere in all of the medical institutions that you see around, nursing or otherwise, health sciences, you see this, health for all, especially for the poor, marginalized, as a vision. But we can't go on doing the same things and expect different outcome. We have been doing this for the last 50 years, and we still are in it. There seems to be some hope that this could be part, RA 11223 could be part of the solution, no matter how imperfect. But it's a paradigm shift. We need to shift. If we are to expect better health status, we need to focus not on the medical factors, but also on the SDH, the social determinants of health. If we miss that, we miss half the problem, or half of the solution. In fact, more than half the solution. Keep this in mind, because I'm going to mention that many times in the next few slides. All right. This is really slowing down my presentation. Health professional education and training really need, I will be very consistent with the tradition of Jesuits to express only 3 in 20 minutes. 3 points for you, because I can consume 20 hours. 1, outstanding health. We cannot simply produce outstanding health professionals. All of the 68 medical schools licensed can produce. But we need to produce agents of change, because there is a paradigm shift that we need to put into actual implementation, and of course, manage what we said, the social determinants of health. If we don't manage the social determinants, we're only managing half of the wicked problem. Please, come on. Education and training of health professionals, including under the paradigm shift, I cannot but take a look at the program learning objectives, also the structured curriculum, and of course the pedagogy, how we roll it out. Of course, always keep in mind the SDH, please. Do keep this in mind. Let's look at the Medical Act of 1959. It's 64 years old. Thank God, our Congress last August 8th approved something that's unnumbered substitute bill to this Medical Act 1959, and it says it's going to be the model of healthcare system in the Philippines to promote access to quality and cost-effective preventive, curative, palliative health services. I hope I haven't done reviewing the bill. Now let's look at the more recent ones. CHED Memo 18, 2016 for medicine, CHED Memo 15, 2017 for nursing. Now I plotted out in the table the learning objectives and the curriculum structure and the content pedagogy. Look at medicine, 5 out of 10 learning objectives. Number 3, 5, 6, 9, and 10 somehow are referring to or may be the learning outcomes that can address the SDH. But look at nursing. There are only 3 out of 14 LOs. And, however, No matter how many, there are 5 over 10 for medicines. Look at the curriculum structure. It does not constructively align itself to the LOs. Look at integrated topics. That's not coursework there. Topics of leadership and management and interprofessional education. They're merely topics. They're not courseworks. There's no units there. Nursing has only one, NCM 119, or leadership and management. And here we are to produce health professionals that will address the SDH, or must address the SDH under the new paradigm. Now, many are saying health professional education and training must be interdisciplinary. It has always been interdisciplinary since about 60 years ago. It has to go beyond interdisciplines. It has to be trans-professional or interprofessional. I'm glad there are many among you who are not doctors, because we need to get together. And the doctors in the room, please, let's start thinking. We're not the solution. We're just a part of the solution. All the rest of the other professionals that you see there, the engineers, they should work with us. We should work together. The finance guy, the bankers, we can't work without them. It's about time that we understand that health is not the problem of the doctor and nurses. It's the problem, as we heard earlier, of the whole society, every sector. And in fact, it should be transnational. Let me give you an example. The health professionals. WHO says by 2030, there will be a shortfall of 18 million health workers. And who are the victims? Not the first world. It is us. Low and middle income countries. They will suck out whatever we produce. If we don't change the way we do things, we will suffer the brunt of health professional deficiencies. Second take home, systems thinking. If we are to train our nurses, educate our nurses and doctors, it has to be system thinking. Stop focusing only on science. We're brilliant doctors globally. No doubt about that. But is that the solution? Every time we think of health, we think of health service. What about the rest? I couldn't think of health financing in the entire country without a health information system. Forget it. We're just building another area for corruption. Systems thinking will lead us somewhere outside of what we're doing. Did you ever wonder where the physician assistants concept come from? They're not doctors. How about the nurse practitioners? Why don't we call what we need not nurses? We call them, let's say, I was thinking last night, what about caregiver practitioners? They have the competence, but they're not nurses and doctors. Calling on Dean Joey of law, maybe you should craft new laws. Don't craft laws for nurses and policies. Maximize the use of technology. Professor Dr. Suit, I'm a certified and trained robotic surgeon, but I have never gone into practice. Why? You're correct. It lifts up the cost of healthcare, but it doesn't necessarily improve outcome. So I spend a lot training, but it's down the drain, Hurts me. Telemed, Gen AI is something that can help us. If we lack human resource, we might be able to use AI. Research is something that we can explore, calling on the director of ACRI, Dr. T.P. Tanchanco, she's there. Innovation. Maybe the K-12 graduate in STEM can be trained in becoming a competent, not a professional, but competent in certain areas, not necessarily becoming a nurse. Last take home, social accountability. Who is teaching social accountability in medical schools? Calling on all SUCs and LUCs. SUCs is State University Colleges. local government, universities, and colleges, what is your social responsibility as a school to serve your local government or the national government? Dr. Suwit says they don't teach English to keep their people in Thailand. We were there last month to learn from the Thais on how they do how are they doing in their 21-year-old universal health care, 2002, correct? Dr. Suwit. They prepared 2 decades prior to enacting the law. We did the other way around. We enacted the law, and now we're preparing on the demands of the law. We put the carriage before the horse. Now, we need to really get down into admission, formation of health professionals, and placement. We heard it from Dr. Suwit. Placement. But admission. Do we get those who have all the ambitions to get out of this country on the first day after the licensure examination comes out? Formation, values, social accountability. We should start measuring what's the social responsibility and accountability of our souks and looks and even private institutions. Summary, health equity or inequity is a wicked problem. And because it's a wicked problem, we might have a solution. This could be a seed, no matter how imperfect it is. RA 11223. And because this requires a paradigm shift, we need to cover PLOs. The program learning objectives should be aligned to it, systems thinking, strong value proposition in all of our med schools. Thank you.
Thank you, Dodi. So at this point, I would like to open this discussion with our other panelists here in front. If you have comments or questions, or would you like to give your reaction to the topic? Sir? No, yeah, anyone. It's a free discussion.
Okay. Yeah, sorry. Actually, I came with a PowerPoint presentation, and I noticed our timekeeper is very strict, so I'll try to fit only into 7 minutes. I will share the floor with Assistant Secretary Levinson Alcantara of our Department of Migrant Workers. My name is Hans Kakdak from the Department of Migrant Workers. So first, I suppose the trends are in order. So we will just I'll just share a few pieces of information with respect to the deployment statistics that we have at the Department of Migrant Workers.
Okay.
So
sir,
first,
for a while.
Yeah.
So I think you'll now be presenting. I thought we will just open first the discussion for the topic.
I'm sorry. I got
if
lost.
you want, we can give you now the floor. Is it okay to give him the floor now to present, and we will just have the discussion later? Okay, thank you, sir. So, our next speaker. So the next speaker, of course, to present the perspective on the migrant workers, on the effect of this HRH, is the Undersecretary for Welfare and Foreign Employment at the Department of Migrant Workers. Please welcome Undersecretary Hans Leo Kakdak.
Okay. Sige. I apologize. I got lost. Okay, so now I have a chance to greet some members of the audience. Sec Ted, of course. Good to see you, sir. Sec Manolet. And Deans Joey and Dodi and Randy and Dr. Suwit, Dr. Joanna, and my fellow finalists. Okay, so we have, these are just 2 slides, and I'll try to be as brief as I can. As I said, I will share it, I'll share the floor with Under Assistant Secretary Levinson Alcantara, who's a real expert among the ranks. I'm a ceremonial expert So I will just run through the trends. I'm sure that would be of interest. On a global scale, first and foremost, it's really a series of notes given to me about the global trends, but perhaps the thing that jumps out here would be the percentage of foreign-born or trained health personnel varies by region and by occupation. In OECD countries, for instance, the proportion of foreign physicians would be 36% as of 2020. In the Gulf states, it would be 70 to 80%. And in accordance with a study by Toyan Thomas, Ikuronian, and Omoyibo, from 1970 to 2022, they analyzed medical documents from different countries, and the low middle income countries with the highest number of workers, health workers, would be South Africa, India, and the Philippines. And the top destination countries mentioned would be the UK and the US. With regard to the local trends, the Philippine deployment trends, nursing professionals, of course, would top the list in terms of the most deployed category of workers. That would be that one there, the rightmost slide. And the preliminary data, though, from 2021 to 2023 suggests a slight recent decline in OFW nurse deployment. A slight recent decline, but not significant, obviously, given, as I'll explain later, the significant push factors of migration with respect to our health workers. In the first semester of 2022, nursing professionals claimed the top fourth deployed skill group, and during the same period in 2023, the group dropped to around top fifth, with the fourth spot taken by cleaners and helpers in offices, hotels, and other establishments. And of course, on the other slide, you will see, on the rightmost slide still, you would see that the top 5 deployed OFW professionals would be the nursing professionals, the nursing associate professionals, medical imaging and therapeutic equipment technicians, dental assistants and therapists, and medical and pathology laboratory technicians. And the top 5 migrant HRH destination countries, Saudi Arabia by far, you can see the disparity. Not too many people know that Saudi Arabia is actually the top destination for our nurses, our HRH. And UK would be second, a far second, third, and fourth, and fifth actually would be UK, Germany. The UAE would jump out as significant pre-COVID stage. It lowered or decreased in the COVID era, but we're expecting another surge with respect to Gulf states such as the UAE and Qatar. And of course, I have some slides, more specific data, which I could leave with the Secretariat. With respect to job orders or the demand, this would be the listed or registered demand for health workers in the DMW database. Saudi would still top the list, around 22,988 sought healthcare workers. UK 12,268, Germany 6,372, and the US 6,054, and Singapore 5,307. Okay, so once again, I have all the data that I could provide the Secretariat for sharing to the audience given our time constraint. But let me also say that we have bilateral engagements with host destinations with respect to healthcare workers. And we have what we call government-to-government arrangements, which is distinct from the general bilateral labor agreement, which is more of a coordinative, cooperative arrangement. But in G2G, as we call it, there is a clear undertaking by the Philippine side to recruit and to send workers, but not obviously in a widespread scale. I need to emphasize that because SecTed is here. JPEPA, this is the Japan-Philippines Economic Partnership Agreement, which is a lot more than just deployment of nurses and care workers, obviously. But there is a chapter there. It's a 22-year-old or 20-year-old agreement. We have a long-standing agreement with the Ministry of Health of Saudi Arabia, and we're very mindful of the deployment of nurses to Saudi Arabia. One, because we know that in Saudi there is a very strong demand for healthcare workers, especially with the advent of universal healthcare. And as you know, they have sort of a, should I say, not a welfare state set up, but I should say a highly functional healthcare system that provides world-class health services to their citizens. We have Germany, what we call the triple win arrangement between Germany and the Philippines, and one on caregivers with Israel. The main purpose of the G2G arrangements, aside from providing protection to workers, is to at least open avenues for cooperation and coordination between two host governments, especially in the area of welfare and protection. So, should I say, when there is a G2G arrangement, the chances of welfare and protection are doubled or tripled or a lot higher than, say, a regular free market recruitment or deployment of an overseas Filipino worker. Just a short note on caregivers before I forget, because Dean Dodi talked about caregivers. Two days ago, the Philippine Caregivers Bill was passed on third reading at the Senate, which is supposed to maximize the caring potential of our workforce and professionalize the caregiving sector. So that might be of interest to everyone here. Factors in migration. Most of these we already probably know, the pay-related drivers or financial incentives, career advancement. The study that I had mentioned by Toyin Thomas had noted that on a macro level, remuneration is 83.2% of the reason, the main push factor why people leave. On the meso level, career prospects at 81.3%. Micro level, family ties 61.6%, improved quality of life also there as well. So it's pretty much clear that there are drivers of migration that we already know. Salary, for instance, with respect to government nurses, a clear disparity between government to private nurses salaries here, in contrast to the salaries abroad. I won't go into the details of this because we'll just get lonely after I give you the details of the salary disparities. There are common drivers of non-migration pointed out by the study, and this is of interest. Local pull factors will include family ties, job satisfaction, and advancing age. And for the foreign push factors, there would be social, cultural barriers and the costs of migration. With respect to current global conditions, the COVID recovery, I think that is with the next slide already. COVID recovery and population aging needs as the countries are struggling to recover from healthcare gaps exposed by COVID-19 and face the imminent reality of aging populations. Migrant workers have filled essential health and care gaps during past crises and are expected to continue to do so. And the priority of attracting healthcare migrant workers is evidenced in updated 2022-2023 special migration corridors. The countries in nearly every world region are prioritizing healthcare worker recruitment, while also tapping into the global talent competition by offering updated fast-track skilled migration pathways and critical skills lists for a plethora of healthcare roles, and engaging in MOUs with origin countries. So everywhere, just about everywhere, also brought on not just by COVID, but by universal healthcare all around the world. You have Africa and Oceania and the Middle East, in Europe, in Asia. In Asia, for instance, in September 2022, the Singaporean government expressed interest alongside the Philippine government when they signed a joint communique to work on or to discuss the work of or deployment of nurses and healthcare workers to Singapore, not in the tone of promoting deployment or recruitment, but in the context of ascertaining who will be best protected in terms of safe and fair pathways to migration. The negative impacts on the question of how does migration affect the equitable distribution of HRHs for UHC in the Philippines, the negative impact of COVID-19 recovery and the potential acceleration of HRH migration due to current global conditions may lead to increasing vulnerabilities for countries already in the workforce. And that's why we have a mission critical skills or an MCS framework that we had worked with the DOLE and also with the DOH, where the government can adopt a policy to address the injurious effect of unchecked outward migration by taking into consideration local demand for certain skills, availability of qualified employees, number of MCS deployed abroad, and prospective entrance of MCS over a period of time. And there is a Philippine skilled occupational shortage list that we are aware of, and it's a vital document that we work with in terms of sitting down with the DOLE and the DOH to determine a repository on names of workers as well as employers who would fall under the MCS or mission critical skills category. Given the time constraints, I will jump to the matter on the challenges, and I will ask Asik Lev to come in as well. Also based on the National Human Resources for Health Master Plan, there are at least 4 identified challenges. One would be multiple fragmented HRH information systems. So Philippine HRH data standards, data sharing, coordination, and governance structures are either not in place or need strengthening. This has resulted in the development of multiple systems, difficulty in harmonizing data, and gaps in data quality. Pay disparities, need we say more? There are substantial wage differences for health workers hired by national versus local governments, between those in public and private and those domestic and abroad. Some health workers shift from health to non-health careers due to higher pay. Third challenge would be the steady increase of HRH migration, increase in international demand, and push factors given struggling post-COVID global conditions, and the potential for brain waste. And by this we mean migrant HRH that is underutilized in the destination country due to barriers to professional certification needs or mismatch. Lastly, as mentioned by Doc Joanna, the lack of reintegration strategies, and the DMW we don't as yet have a specific reintegration plan for healthcare workers. We will be honest about this. However, the framework presented by Doc Joanna is well accepted, and currently we would just only be too glad to sit down with SecTed and his team with respect to developing a master plan for the NRCO. And speaking of SecTed, my last point will be our bilateral engagements, because SecTed sent me a short message on this and pinaalalahanan kami ni Sec. And just to inform everyone, what do we do exactly when we engage foreign governments? Because the media has projected this so much in quite the other way that we want it to be projected. But when we engage foreign governments in talks with respect to healthcare workers, we are looking out for provisions that protect and promote their welfare. So we check upon their coverage in Social Security in the host country, fair, ethical, and sustainable recruitment policies. This is key because there are many illegal recruiters of healthcare workers here in our country. Combating human trafficking, equal treatment with the locals or the nationals of the host country, and fair, just, and commensurate compensation at par with local counterparts. This is similar to the point about brain waste that I had mentioned. And with regard to healthcare jobs and cognizant with the need for sustainable supply of our nurses, we incorporate provisions on scholarship grants and faculty development. This was actually the brainchild of our late Secretary Toots Ople. And she, at the time of her death, she was busy setting up a scholarship program where the idea is to get to source for public and private funding to develop a scholarship fund to harness healthcare potential and healthcare enrollees in schools, and thereafter have a commitment similar to what Dr. Suwit mentioned, have a commitment on the part of the healthcare graduates to serve in government or serve in within our country and not immediately go abroad, at least until they've served the commensurate or the counterpart equivalent of the scholarship grant that's given to them. Last na lang, I need to mention the OFW hospital. It was a hospital created during the time of President Duterte. And in a nutshell, I won't get into the details of the framework of the hospital, but it's a hospital catered for OFWs and their dependents. The services are free. And it's in San Fernando, Pampanga, and this too is contributory to the healthcare, the universal healthcare system, of course, with respect to OFWs and their dependents. But I'd like to point out one little matter with respect to the hospital as it relates somewhat to reintegration. Next, sir. Ayan. Well, the left slide is the census of services rendered by the hospital. I won't get into the greater details of that, but maybe just to point out that in the outpatient and inpatient categories, the figures are there, and lab work and radiology work, there's equipment there. You're free to visit the hospital if you like to service the incoming patients. But the right-hand slide is where I want to end, and it's the number of staffing requirements that we have, that the hospital would have. Currently, there are around so 210 plus 84, so roughly around 300 in the working in the hospital, but the desired target is around 500. So that could be a reintegration program in itself for returning nurses and doctors from abroad. Many have already volunteered, but we wish many more former OFW nurses and doctors could come join the OFW hospital. I'll end there, but I would want Asek Lev, if you please can give him the floor to supplement anything or everything that I failed to mention, Asek Lev. Okay na? Okay. Sige, I'll end there. Thank you very much. Sorry.
Okay, so instead of the interactive discussion, we'll leave the interactive discussion at the end of the talk of all our speakers or experts. And we'll proceed now with our next speaker. So again, I would like to remind our speakers, we are only given 7 minutes to deliver your talk. So the next presenter is the Senior Research Fellow and Program Director for Leadership and Innovation at the Ateneo Policy Center School of Government and a former Undersecretary for Health Regulation at the Department of Health. Please give a warm welcome to Dr. Kenneth Hartigan-Go.
Thank you very much, Ronjin. Good morning to everybody. Proceeding to my short talk. Okay. straight out of the website of WHO, we know the definition of universal health care. We all agree that, echoing Joe Banson, that universal health care is our ultimate aspiration. Question now, how do we get there? So leadership and governance is one of the pathways. This slide, I'd like to tell you a brief story about this slide. I had an awkward moment with President Fidel Ramos. The two of us were in a room, and he was president, and we had to have some conversation. So I asked him, how is it to be a leader and being the president? And he told me a story. He said, look, think of yourself like the juggler, balancing yourself high up in the air in a tightrope, and then balancing, juggling 4 or 5 balls of equal importance. And people down there are cheering you up. There are people down there throwing rocks at you, hoping you will fail. And that's the life of a leader. And then he said, I forgot to tell you another thing. There is no safety net at the bottom of that cliff. So if you fall down, you get all the pains, hurt, and everything else. So this is where health leaders come in, and I'm sure that many of you are in the room, gravitate and resonate with this issue. Gone are the days of the strong, silent leader, and where it is very lonely at the top. Leadership today is all about asking the right question. And one of the things I learned from Paulo Borromeo over there is, sitting with him in various meetings, he would ask questions. And importantly, no one expects everybody to know all the answer, okay? And because of that, management gurus now believe that when you ask questions, it shows humility, it builds trust, and it creates collaboration. Sometimes asking the right question is half of your solution. So, second point I want to make is systems thinking. The leaders should be willing to connect the dots, and that calls for systems thinking. We cannot solve the problem with the same mindset that got us into the same problem in the first place. Crucial for us to develop this, and not everybody can have this. Some of them even go as far as thinking out of the box, creating conspiracy theories. So now I'm going to show you another important point. And this has already been, I just want to make a point that Sir Michael Marmot spent his time in the Philippines, in the Philippine Heart Center, looking at community health. And he was the leader of this Lancet Commission that looked at social determinants of health. And I just want to mention that former Health Secretary Manuel Darid in the audience, in fact, was one of the commissioners of these social determinants of health. So the principle here is that he pointed out factors like education, income, housing, though not health-related per se, can greatly influence health outcomes. So what does it mean? Leadership and governance is do not bring the usual suspects together. We have to be a multi-sectoral. So I came up with a few questions that will help us reframe the issue, if you bear with me for a while. Created out of a vision, this universal healthcare, are we in fact fulfilling our mission? The question is, do we have a shared vision? It might be clear to you, but it's not clear to everybody else. The next question you should ask, do we have a playbook on how to implement universal healthcare? And does this playbook even specify the roles of everybody and every member of the health team and health leadership? Healthcare is one of the building blocks, which is human health resource. I think you have to ask this very difficult dilemma, philosophical question. Is healthcare a commodity of trade? Or is it a public good? Some of the industry complaints saying healthcare sector is one of the tightly regulated industry. Doctors have to be licensed, nurses have to be licensed, drugstores have to be licensed, medicine as well, hospital has to be licensed. Now, look, with all this licensing, are we in fact creating better outcomes? Why is the outcome the way it is right now? We have to accept that healthcare one day is going to be rationed. This is not enough for everybody. And this is a picture I got from Abandoned Ship. No? Do the various laws and regulations governing health professionals enable universal health care, or they in fact hinder it? Because if you're thinking of disciplines, it's not going to work. You have to start cut across it. That's resonated with some of the talks earlier. Now, WHO has mentioned that, well, I just want to make sure three existential crises. WHO mentions there are going to be global shortage of health workers, rapid expanding health information, and rising use of technology. How do we create that nexus to bring that together? The important information I want to share from a leadership perspective is that we have to reframe dealing with our human health resource as not professionals or discipline. We have to think of them as teams. And it's very rare to find groups of people bringing them to as teams. No? How can we even, this problem of human health resource crisis is going to be a national security problem. And how can we engage the rules of engagement using economic diplomacy to deal with other countries to serve our best interests? So 3 things come to mind. Policy. The next one is strategy. 2 things. Strategy tells us where we are and how we will get to our destination. And this slide is from the Commercial Determinants of Health that recently came out in Lancet in May 2023. If you want to get on this 3 set of articles, will tell you how to deal with the private sector. This is it. No? Now, in the banking and insurance sector, there is a strict requirement that board directors and top officials undergo training. And the health sector does not have such a model of engagement. My proposal is in this strategy, what if every director of healthcare sector undergo a mandated training on universal healthcare, and what are their obligations sitting in the board? Now, you mentioned that human resources, not just the frontliners. The people who govern are in fact the board of directors of medical institutions, drug companies, and the like. No? And they should be really part of the national implementation, looking at governance, audits, and risks. I have yet to see a medical school formalize a universal healthcare training course, integrated into their curriculum. And we also need to have an actuarial study on compensation looking into the future. So down to my last 2 slides. No? The last part, after policy, strategy, and in leadership we talk about execution. The success of any policy is really in execution. Now, the question we need to ask of ourselves is, do we want to change the tires when the car is running? Or do you want to reboot, stop, and start everything from scratch? And as Darwin Mariano, a colleague we work with in Optum, says, how shall we manage the flow rather than the flow managing us? So there is really need to create an environment conducive to health workers' work. That has been mentioned by Joe Banson. And this, the principle is how the leaders treat health workers will reflect on how the health workers will manage our patients. Think about it. You treat them badly, they're going to provide bad quality service. Treat them better, they're going to do a better job. So each link in the value chain I want to share with you is to look at recruitment, education, employment, compensation, retention, then migration. We have to look into the future, anticipate what's going to happen in the future. If you're interested, there's an article in the public domain called The Economist. In January 2023, they came up with a forecast of what the future of healthcare will look like in Asia. I encourage you to read it, so understand and be prepared for it. No? So in closing, I want to reiterate that healthcare is everybody's business. We hold tiny bits of the puzzle put together, but in leadership and governance, we're looking for more horizontal managers who can do the being a conductor of a large orchestra and be able to put all of us together to achieve universal healthcare. Thank you very much.
Thanks, Ken. So for our next expert panelist, we're lucky to be graced by a very hardworking public servant. She's the City Health Officer of the City of San Jose del Monte, Bulacan, and here to discuss with us the public sector perspective. Let's give a round of applause to Dr. Rosel Tolentino.
Good morning to all, especially to our distinguished health leaders
in this room, especially for our mother national agency from the Department of Health, Dr. Teodoro Herbosa, and from the private sector, the AC Health. Shout out to the Healthway, San Jose del Monte Qualimed, and of course, the Ateneo de Manila University, fellow public servants. So, it is an honor to be part of this undertaking and to be heard on our perspective on the part of our sector, which is the public sector, specifically the local government unit. Being on the ground and at the grassroots, the human resource for health is the most significant component of the local health system. And this is to be able to deliver health services and of course, implement the different DOH programs. And HRH, in its variation in size, distribution, and composition, have the influence on the local health system's effectiveness and performance. So as we gear towards UHC implementation, it is vital to have a sustained and effective system of HRH management and development, especially in all local government units through its city and municipal health offices. So relative to that, at present, we are hurdling challenges to be fully equipped and be able to compete with what is for the quality health services in terms of the health services, human resources for health in the public sector. So in the interest of time, I have 2 slides also, and there are points to discuss, which is one is the specific issues on HRH in the public sector. So at present, one issue is on HRH supply and distribution management. So on the primary care area, which is nandun po kami, there is still limited primary care health facilities for which this health personnel will be distributed. And with the standards given by the DOH, that in every 20,000 population, we should have one at least primary care facility, and in every 5,000 population, we should have a barangay health station. But at present, it is unattainable, but we are accepting the call to be able to attain that goal for the UHC. And with that, there are also standards for us to be accredited primary care workers, and of course, primary care facilities that we are into. So for every 50,000 population, there should be one rural health physician. And for every 10,000 population, one public health nurse. For every 5,000 population, one midwife. And for every 50,000 population, one dentist. I'm sorry, it's 1:20,000 for doctors and sanitary inspector. So the minimum personnel in every primary care facility includes one rural health physician, one public health nurse, one midwife, one sanitary inspector, one dentist, and one utility worker. And other issues that is also present within our sector is also the area on administrative personnel. Yun nga po nasabi na before and even now, but we are trying to fix that practice that even nurses, midwives, and a multitasking doctor can do also the administrative works. Like for example, record management, data management. So in our locality, we are trying to fix or follow the standard that in terms of data management, record management, and other administrative matters, there should be personnel that will function on that aspect. And another issue is the unmet standard staffing based on the function and recommendation ratio of HRH to its population. So that's what I said a while ago. Yun pong standard na tinatry po naming i-comply. Kasi at the end of it, it's also the delivery of services that at least we can conforming to what is on the standard. And of course, the limited human resource for health plantilla position related plantilla position. And of course, yung pong maldistribution of human resource for health, especially in GIDA areas. These are areas which are geographically isolated and disadvantaged. So like in our locality, we have 4 barangays under the GIDA areas. And may mga sitios or barangays po that we need only through walking. Aabot po kami doon ng 2 hours at most para marating po yung sitio na yon. So it's still the present situation, but with the leadership and governance of our local chief executive, as we say, nasa pamumuno po yan ng local chief executive if health is her or his priority. And that's why kami pong health leaders on our part as city health officer, we need to update our local chief executive in terms of the updates, in terms of policies, and also at most, we have to give them good accomplishments. Kasi like in public health or sa area namin, we have targets to attain. So in every services that we have for maternal and child, even yung ating ESO, Dream Age, and other health services, there are targets to be attained. So, in terms of working conditions also, the security of tenure. Kasi nga po, in the local LGU, at most po, marami pong job orders or plantilla positions are not readily available. And of course, yung learning and development interventions, so as what I heard, na ang kailangan po ngayon, it's not only the technicalities, but it's more on how to mold our primary care workers to have that competency in terms of leadership, in terms of supervisory management, and of course, yung ating attitudes and personality na dapat din pong kailangang merong mga trainings on that. For long-term doable solutions, so yun nga po, since there is maldistribution, ang kailangan po ngayon is really to have a lucrative or at least providing opportunities for decent work for those HRH in the public sectors. Yan din po ang dilemma namin. Pag meron na pong opportunities outside the country, unti-unti po silang nagre-resign and they will be going there. So, for the past 2 years, after the pandemic, dumami po ang nag-migrate in our locality. And of course, what are the programs that we are trying to align with what of the UHC is to have a plan, good plan in terms of human resource for health development plan. In our locality, we have our 2024 to 2030 HRH development plan, and we need to present it to the local health board together with the re-engineering committee and of course to our local chief executive para po maintindihan na talagang we are multitasking. Kami po sa primary care facilities namin, nagmo-multitask, but we need to be augmented, although with the process of augmentation from the DOH, still it's not enough. And of course, yung ating intersectoral collaboration, so during the time of pandemic, there is an evident collaboration between the private and public and other intersectoral agencies. So that's all. Thank you.
Thank you, Rosel. So I would like to remind the audience to kindly prepare your questions. There are microphones there beside you. If you will not ask question, then I will monopolize the mic to ask question later on. Anyway, so we are in the last panelist, the last but certainly not the least, who will be tackling the issue of HRH from the private sector perspective. Our next panelist is the Group COO of Healthway Qualimed Network. Let's warmly welcome Mrs. Gaget Bengzon.
Hi, good morning, everyone. Thank you, Jean, and thank you to the organizers for inviting me today. Just driving in today, I was thinking about the fact that there's really no better setting for us to help have this summit on health human resources here at Ateneo that is home of the ASMPH, which is really, and this is not a biased opinion by any measure, really the greatest innovation in medical education and generally health human resource development specifically. And I'm just so proud to have been part of the team of Dr. Bengzon who put forward this vision and saw it to realization. We have something like close to 2,000 graduates already, doctors, leaders who people said, never could happen, but it's a reality and the groups are growing and the future really looks bright if this is what our doctors are coming forward. Equally proud now to be part of the AC Health family. Still relatively small, relatively new in the healthcare space, but already really recognized as a leader in thought, leader in action, more importantly. Particularly as a result of our engagement during the all of society, all hands on deck pandemic response that the government organized. For purposes of today, I'll focus my discussion on the nursing challenge, particularly in the hospital setting. It's really the most acute, the most chronic event, the most serious, and really looms the largest in terms of this whole health human resource question of challenge. And I'll describe strategies that we're pursuing from the private sector along three fronts. Strategies that we pursued during the pandemic in a crisis situation. Strategies that we're pursuing now as we're working to stabilize, working to grow. And also strategies that we're putting forward now to advocate in the broader area of health sector reform. And So we in AC Health, we acquired the Qualimed Health Network in 2021, just as the pandemic was raging. And this is what constitutes our network, and I'll call your attention to the 4 acute care hospitals that we have in Santa Rosa, Tanawan, San Jose del Monte, and Iloilo. And even before COVID, since this nursing challenge has really been long-standing, the hospitals were already really challenged by this whole difficulty in securing enough staffing for the nursing as well as other healthcare professionals. And all the more, during COVID, when all our emergency rooms, all our ICUs, all our wards were really full to the brimming in terms of all these COVID patients that we need to take care of. And in Qualimed, we actually made it more challenging for ourselves because taking a cue from the imperative of Ayala to really step up our pandemic challenge, we actually built up our COVID bed capacity to double what the government required. And you can imagine that this made the effort all that more challenging. And if you call at this point, really infection control protocols were just developing. Definitive treatment was a good, year away maybe. And so the shortages were even made more problematic by nursing staff that was falling ill, and then nursing staff that was falling out of the plantilla, some without even notice. Really as a result of all the physical, the emotional, the mental burden of taking care of all these patients, dying patients, and also taking care of the families who couldn't be with the patients and their loved ones, in the hospitals at the time. So we provided the essentials. Hazard pay, even hazard bonuses, transport, meals, PPE, healthcare benefits for them, healthcare benefits for their families. We even engaged mental health professionals to really help our staff with deal with the emotional and the mental burden of dealing with so many sick and dying patients, and also putting themselves at risk and potentially putting their families at risk as well. But this is a lot, but this is just, you know, the basics, the baseline. You know, there was so much more that needed to be done. And so we thought about, you know, what can we do that's more substantive from the operational, from the organizational level. And what we did is we really made an inventory of all the things that nurses do that are actually better done by other staff in the hospital. Some are administrative in nature, and others are actually involved direct patient care, but are safely delegated to alternative caregivers. And we even delegated up to our physician staff. Now, other than Tanawan, we don't have a residency training program, so we're very much dependent on hospitalists, which I'm sure you know are, you know, notoriously less than fully dependable. But we really made it a point that they pick up the slack, particularly in this crisis time. And so we revised their workload so that, you know, they took on more ER shifts. They made more assessments on the floors to really supplement the care that the nurses were providing. And we put in the organizational arrangements to support all of this. We created a care team involving 1 nurse, 2 nursing associates, 1 ward clerk to take up the admin tasks, and then nurse technician or orderly to do the errands, heavy lifting in terms of patient transports, equipment transports, and that. And this really cut our nursing requirements by 1/3. But even that wasn't enough, no? Because in a crisis period, you can never go it alone. You should never go it alone. And so AC to AC Health early on had decided we're going to take a leadership position in supporting the government in beating this pandemic. And so that's a whole other adventure in itself. But at this point, suffice it to say that we contributed a lot, but we also gained a lot in terms of having a voice at the highest levels in terms of policy development, and also on the ground operations in terms of networking, in terms of resource sharing, including resources such as very critical supplies and even nurses. And all these strategies put together did actually produce excellent results. In terms of COVID care, if you take a look at our outcomes, the Qualimed hospitals met and even beat many of the US hospital benchmarks. And really so proud that we're able to do this, even if these hospitals in the US are so much better provisioned than we were and we are. And last year, as it was beginning to look like, you know, the worst of COVID was behind us, we were thinking about, you know, what more sustainable strategies can we come up with to recruit, to retrain, to engage our nursing staff. And again, we began with the essentials, aligning our compensation scales with industry standards, and really more importantly, restructuring our rewards program to increase empowerment and to drive performance. So we took a financial hit here, but it's absolutely necessary and it absolutely pays off. And at the level of operations, we redesigned our business and clinical processes, really to lay the groundwork for what's a network-wide integrated information system that brings together hospital information, electronic medical records, and finance and accounting systems. And the point of this is to really make the work of our nurses, as well as the work of our other staff, so much more effective, so much more efficient, and so much more productive. And again, we turn to partnership building as a key strategy. Now, we have partner schools in both sides of our family, on the Qualimed side and on the Ayala side. But you know, because of this moratorium on nursing schools, which I have to say is ill-advised and took a long time to be lifted, we're really going to take a time before we're going to be able to benefit from the graduates coming from these schools. So we partnered with other schools who also have strong nursing programs, you know, the usual job fairs, scholarships, for the deserving undergrads, training and preceptorship opportunities in our hospitals. We sponsor review classes for those who are about to take their boards, job offers certainly for the passers, but also job offers for the non-passers who we're supporting to do reviews and hopefully pass in the next go-round. And we also pursued what some might consider to be non-traditional partnerships. Post-pandemic, obviously, this nursing challenge is growing larger, growing geometrically, growing globally. And the Philippines, as we all know, is really the number one on the list of recruiting destinations. The offers are really crazy. We're seeing hundreds of thousands of dollars for salaries and bonuses. And so there's really no way for us to compete. So we figured, if you can't beat them, join them. So what we did is we inserted ourselves into the whole global supply chain of nurses. And we now have institutional partners, some working in the US, some working in Europe, who recruit nurses for us, subsidize their training with us, invest in their enculturation, which is really so important for the success of migrant workers. And after 2 or 3 years, place the nurses in one of their hospitals in their network. And for our part, we have a steady stream of recruits. We have some stability in terms of tenure, and we even earn fees for training and placement of these nurses. Now, all of these are investments in our path to future growth, and even at these early stages, we're already seeing very substantive benefits. So we're so gratified with the results of the recent Willis Towers Watson engagement survey, which shows really Qualimed beating handily, not only the top hospitals that participated in the survey, but even healthcare organizations globally in all the applicable categories, and most notably total rewards, career development, empowerment, and accountability, and one that I feel personally affirmed by leadership. And finally, having Ayala into our DNA, we're focused on purposes, always purposes, larger, bigger, higher than ourselves. So our work during the pandemic gave us credibility, gave us platform, and over COVID, and the we here is really a whole of society, really learned how to come together and to work together successfully in times of crisis. And thankfully, these learnings are now being applied post-pandemic. Through private sector advisory councils across various areas of concern, including, of course, health. And Paolo heads up our PISAC for health, and we tease him a lot for all the amount of time he spends personally and how much staff resource he devotes to PISAC. But he's absolutely right in spending so much time personally and devoting all these resources, because having such a prime seat in such a big table really magnifies, amplifies our voice, our relevance, our impact, and really gives us the ability to make changes and really shake things up to make a difference. So using the same framework, we've put forward a range of strategies in and through PISAC, and this time dedicated at much belated and very much needed sector reform. Again, focusing on the essentials. The focus is on addressing certain structural and systemic imbalances in how government and private sector pay and engage. But this is still very much a zero-sum solution. And so we need to think about, again, operations and organizational changes. Because as Dr. Joanna spoke about, this is really about the challenge of not producing enough in number, not producing quickly enough. Especially if the world is looking to us to be the supply of nurses. And the solution, certainly in the near to midterm, really lies in how we can innovate in redefining, in training, in deploying nursing care teams, and doing so quickly and at scale. Very similar to what we're doing at Qualimed, only on steroids now. And in works here are programs such as, training and licensing what we're calling clinical care associates. And there's other nurse complementation strategies as well through vocational programs with TESDA and also alternative BSN pathways. And finally, with respect to partnerships, we might as well lean into our role as the world's supplier of nurses, but we need to ensure that we get something back through bilateral, multilateral arrangements that can provide funding, that can provide subsidies, that can provide capital, that we can reinvest in our healthcare system and our health human resources specifically, so that we're able to meet the needs of our country, even as we're helping the rest of the world meet its needs for healthcare workers. And this is a solution set that we believe is effective, is equitable, is also sustainable. So if you see, the framework works in times of crisis, in times of stabilization and growth, whether you're taking the perspective of an individual institution or the sector as a whole. I would even venture to say that this framework applies for all types of healthcare professionals, doctors, nurses, ancillary staff, auxiliary staff, and also all levels of care, primary care to super specialty care. And this really needs to be the landscape in which we're pursuing human healthcare reform in the context of universal healthcare. So get the essentials right in place, provide the individual with just pay certainty, but also provide them with the power and the purpose so they can perform to the best of their ability. Within our own organizations, we need to create, embed enabling structures, tools, mechanisms to enhance productivity, to enhance performance, to enhance job fulfillment in the workplace. And finally, really reach out kindred spirits who share our vision, who have something to gain as well as something to give back by coming on board, and all of us together can scale up and scale out the intended reforms in the manners that benefits all. Thank you, and excited to attend the rest of the panel discussion.
So we'll now in the open forum part. At this point, we'd like to call Dr. Suwit to join the panelists here in front for the discussion. And of course, our Secretary of Health, Dr. Ted Erbosa, here in the panel. So kindly, we can start. You can now start asking questions. 1, 2, Dr. Gina Nazareth. So if there are other who wants to ask questions, kindly line on the stand up in front of the microphone. Thank you.
Okay.
Hey, Gina.
I have a Miss Universe question addressed to Dr. Kenneth Hartigango. Ken, thank you for your lecture. What do you think are the key elements to ensure UHC traction?
Miss Universe question. Okay. All right. You're probably referring to the iron triangle. For any policy to succeed, there are 3 things that has to be present. And these 3 things have to be equally invested. I refer to the first one being political will. Now, I don't mean partisan politics. Politics is really the leadership decision to make good choices, even though those choices are unpopular. So political will to support. The second part is the investment on administrative capacity. You can't get anything done without the right bureaucracy, knowing what are the rules, regulations, how do we implement it. That ADMI part is important. No? They don't have to be technical human resource and health, no? But they are supporting the back end of the operation, as was mentioned earlier. And the third part of that iron triangle is technical competence. And this is where the health sector professionals come in. They have to project some level of credibility. They know what they're talking about. They have to maintain that institutional standards on quality of care, which I think you will agree with me, this is the work you do, right? Quality of care, assurance, and I hope you understand. So basically, you need the 3 things working dynamically together. I'd like to call it the iron triangle. Okay, thank you.
Okay, thank you. Thank you, Ken.
Miss Universe na ba? Okay na.
Okay na, Gina. Okay, sir, the gentleman there.
Good afternoon. I'm Dr. Varela. So in 3 years, we have already had 4,234 PLE PLE passers, physician licensure exam passers in 3 years. But only a few of them actually pursued residency training. So Attorney Hans Kakdak presented migration of healthcare workers primarily amongst nurses and paramedicals. However, not for doctors. It's because primarily doctors are not migrating to practice their field. No, it's quite difficult because of USMLE and all. So most PLE passers in reality are practicing as moonlighters, general practitioners. Unfortunately, they are being abused by private clinics and LTO, even the LTO clinics, paying them a very few amount, no, for their practice. Now, my question is, number one, is the UHC going to discourage the board passers to pursue residency training? Next is for the plans for the primary health physicians. Will BUH spearhead in providing continuous learning and updates for the primary health physicians? And are there measures that will be provided by DOH that will entice or encourage board passers who are the GPs practicing as moonlighters to become a primary health physicians, like for example, good salary and benefits. And in terms of patient care, will UHC delay the proper treatment for patients just like in the US? Example, I have a patient, I'm a urologist, so I have a patient na who came from the US and eventually decided to have the PCNL done here in the Philippines because there's a delay in 6 months. So is there a program how we can actually provide the UHC, because the UHC is a very good, it's actually good for our country, no, the program. But hopefully, can it provide a faster treatment also? Because unfortunately, if GPs will be the ones to see these patients and they are not updated with the current trends for the treatment of these patients, then there might be some delays in the treatment of these patients. That's all. Thank you, sir.
Okay, so Dr. Varela, you address your question to our secretary.
Kahit kanino po, sir.
I assume that the general barrage of the questions, I assume I'm the one who's challenged to answer those questions. Well, I'll challenge you backwards. I think the main problem of our physicians and the people who are my era, I don't know if you're my era, but you're probably younger, is we listen to people who got educated in a system that's entirely different from those that I went into. So what's very important for the young people here is to look at futures thinking. Do not follow what we say, because I grew in an era that was different. I graduated medicine when HIV was discovered. Similar to you now today, you graduate at the time COVID-19 was discovered. And there were lots of paradigm shifts in the way we did surgery. For example, before, if you remember, we didn't have gloves. We sutured in the ER without gloves. But because HIV came, we changed that. So things actually change after because of factors. So my answer to all your barrage of questions is, it's very difficult. See, what I want to instill is, number one, systems thinking. What is the system you like? So I always go forwards. I start with the end in mind. And what is the end in mind, diba? UHC. If you start with the end in mind, you will know what you'll do in the beginning. You won't know, but if you ask me with a lot of questions of what will happen, should I stop specialty, should I push primary care? You know what I tell you? These students that graduate, they have such a thing as a year off. Have you heard of that in your generation? You don't hear that in our generation. We were educated by our people to study medicine, don't stop, and then go to residency, then work and continue, get married, etc. But now our kids are different. Our kids want life-work balance. So they go into this job, the moonlighter, it pays well. They work at the time they like. They've now controlled their lives. They go to Boracay when they're not on duty, and then when they don't have money anymore, they go back to the hospital and go on duty again. And it's a good lifestyle. Actually, it is. Actually, when I started the field of emergency medicine, that was already what was happening. I was creating doctors without making doctors, because the ER doctor worked on shifts. It was different from me, who was trained as a surgeon. I would actually stay in the hospital forever. I never went home. I stayed with the patients I operated on and everything. It was a hard life. So it's very different. I know you're a urologist. You were probably trained as hard as I was. But the kids now think differently. So I think they will form the future that they want. We shouldn't. You should form that. You should imagine what type of universal healthcare you want, and then you build it. Thank you.
Thank you. Thank you,
This
sir.
universal answer.
Dodi, you want to add something?
Yeah, we have emphasized systems thinking. That's we always look at health systems in all of its. I don't think Ted. I think we graduated almost the same time. So we were educated in the old system, and that has to change. As we said, if we do the same things as we did, we will never reach UHC. We'll never reach that. That's an aspiration that will never happen. We have to do something different. We need to do things differently. we need, that's why, I even challenge the lawyers here. Maybe you should think about laws that will recognize not nurses, but will have similar competencies, maybe broken down into various pieces. In Medical City, we have 13 high-end, fully complemented operating rooms. We're running only on 6. Why? We don't have nurses. We don't have nurses. So the issue here is, how will it ever be filled up by nurses? I doubt it. If we run this course, if we produce the same or even increase the number of nurses, they will be employed by rich countries. We cannot compete. We will always be on a deficit. And that's predicted already by WHO. The poor and middle-income countries will always suffer a deficit, whereas the rich, they can always suction in the people. Yeah. So, please. So we need to do things differently. Dr. Suwit, they did not teach English. Why don't we create? Why don't we create? I was thinking very badly last night. Why don't we create an entity or a health practitioner called, what did I call it earlier? A nurse giver who is a practitioner. They will never get employment abroad because they're not qualified as nurses. But they can work for us as a competent, let's say, assist in the operating room. We have some people who are very competent, very skilled, but not necessarily nurses. So calling them with a different name, creating, if we don't do that, we will always be in deficit. That's the issue we face.
Yes, Dr. Suwit.
This is what we did back in late 1980s. We established rural hospital all over Thailand. And we cannot wait for 4 years nurses. So we create a new career called technical nurse. Technical nurse. 2 years of education after high school. And we can produce them very fast. Very fast. It may fit for Philippines because technical nurse cannot be exported. Yes. Because they are 2 years. And actually, when they work in the rural hospital, we use them the same as nurse. The same. Not much different than the graduate nurse.
Ken, you want to add?
Thank you. I have a philosophical question. And that because we think that the marketplace follows law of supply and demand. But my question, medicine, healthcare does not. But my question now is to the foreigners who are getting our healthcare worker. Why do their own citizens not enter into the field that is serving their own citizen? Is it because their quality of education is bad? Did they not compensate them well? Or their people just simply do not want...
I'll answer your question because I asked that question with the diplomats. I did.
Oh, please.
Because they don't want nurses, they want Filipinas. No, that's what they told me. I offered that solution. I said, why don't you get your citizens to come here and study in our nursing school? You know what they said? No, our own citizens will not care for our own citizens. We want the Filipinas because they take good care of the people. So that's another brand. That's another issue. It's not pala the education. It's the way women are in the Philippines.
My goodness.
It's the way. So it's not education. It's a characteristic of our Filipinas.
And we
a very caring woman.
And it's commodified. It's
yes,
commodified.
It's
that
commodified.
Way.
Okay. We have former Secretary DOH, Dr. Dairit. It's your turn, sir.
Just a comment, no? Pick up from Suwit. They're now wanting to make our midwifery course, which our midwives can't go abroad because they're not standard, world standard. But the midwives want to be a baccalaureate degree as well. And when they do that, we're going to be losing the midwives as well. But anyway, this is really more philosophical, but it picks up from what Ken and Gaget talked about, two concepts. Okay, I'd like Suwit to comment because it's like another country person thinking about how we do things. But the first comment is HRH a public good or a commodity? Because public goods are supposed to be inexhaustible, and even if somebody uses it, you don't deprive others. Okay, this is the definition of public good. So I'd like Suwit's thoughts on that, particularly reflecting on the situation of the Philippines that you've heard it this morning. And then the second question has to do with what Gaget said, yung zero-sum game. In a zero-sum game, somebody's gain is another person's loss. So what's the government policy so that that's not the case for HRH? So those are the two questions, and one to Suwit, and for the second one, I guess Ted and anybody else here, and even Hans, can possibly comment. Thank you.
Okay, Professor, Dr. Suwit.
Can you repeat the question again? I didn't get you well. What's
Human resources for health, is it a public good or a commodity? What do you think of, how did you think about it in Thailand?
Well, de facto, you cannot use a nurse and not exhaust other people to use the nurse because they have the same 8 hours or whatever, 10 hours. But if he or she is a public health nurse, then it's different, because when he or she give health education, it's not just one by one, it can be for many. When he or she go on record in video, in YouTube or whatever, it can be used for many times. So for this question, if it is personal health services, it cannot be fully public goods because it exhausts. Once it's used, it's exhaust. You have limited. Okay?
Okay, so I think the second question of Secretary Dairit is, what's the government policy in terms of the zero-sum gain?
Yes, I think the government policy right now is to veer away from the general notion that we are suffering from brain waste or a brain deficit, brain drain, and that now we're looking at ways in which to harness, and it was mentioned by Dr. Joanna and by Sected, how to harness our overseas employment experience. So we have, in bilateral discussions, for instance, I'd already mentioned the scholarship approach by Secretary Toots Oplek. We have giving back provisions or negotiations or discussions with foreign governments. Because the main quality that we have, and this is to sort of also tap into the previous question, is that we have a caring quality. Don't know why, don't know how, but we just have it. It's innate in us. I'm not sure if there's some sociological study to back this up, but it happened to me. I got hospitalized in Saudi. I got the chicken pox. In the middle of the night, another nationality nurse came in, and I said, "Can I have a blanket?" And the other nationality nurse, I won't mention the nationality, said, "You know, laundry comes in at 4 o'clock in the morning." It was 2 in the morning. So I said, "Oh no, I'm gonna have to wait for 2 hours." And then in comes a Filipino nurse, and I said, "Pwede ho bang magkakumot?" At teka, sandali lang ha. Gagawa ko ng paraan. And indeed, she came back with there's just something about us, and I would like to think it's a little bit more than just the English language. We are just a caring people, and that's why the Philippine Caregivers Act that I mentioned seeks to tap into this caring potential in our workforce. You don't need to learn caring, but somehow it's just in us, and it's school and education and training and certification, 2-year courses that will get us into the stature of serving, not in a sense of commodification, as mentioned, but how to harness that caring quality into something that will make the UHC work.
Thank you. I think because of time constraint, we'll have the... Okay, two last questions from the medical student and then from ma'am here.
Good afternoon po. I'm Shalom Hernandez. I'm a medical intern in my 5th year at the Ateneo School of Medicine and Public Health. And I have a question lang po regarding regulation and the private sector. So according to the Philippine Private Health Sector Assessment, 60% of PhilHealth accredited facilities are private health facilities. Hence, majority of the labor demand are coming from the private institutions. So it's just a matter of fact also that public facilities compensate as much as 2 to 3 times more than its private counterparts. As an example, Nurse 1 Plantilia earns 36,000 in comparison to the average of private nurses in private hospitals, around 16K in private hospitals. And from personal background, my sister used to be a NICU chief nurse at the private hospital where her take home was around 14K. And for her to send her kid to a good school, she had to apply at the city health office, and now she's a nurse 1 there. And so with this question, what can be done to standardize or regulate the compensate of health professionals across private and public institutions to incentivize health professionals to stay in the country? Thank you po.
I think that's for Sec Ed.
Yeah, thank you for your analysis. No, it's a nice analysis, but there's something wrong with it. Yes, the private sector is 60% of the healthcare capacity, yet only the public sector has only 40%. But you know what's wrong? Only 20% of the population go to the private hospitals, and 80% of the people go to government hospitals. Then you go to the government hospitals, you will see one of my nurses in the emergency room. She's taking care of one nurse, taking care of 20 patients with 2 intubated patients. So when you tell me the demand is the private sector, you're wrong. The demand is in the public sector because majority of the Filipinos go to the public hospitals and the LGU hospitals because it's free there, diba? No balance billing. So now we need to correct that. That's why it's really very important to engage the private sector and say, I don't want to raise the salaries of nurses there because if they do, there will be more people going to the public sector. Why? Because they will raise their prices. Right? They have to recover the cost of the salary similar to the government. But what you need is to fill in yung timba ni yung timba ni Joanna. You need to fill in the timba of Joanna because you need, the flow of our nurses are from the nursing school to the private sector to the government hospital and out to the United States of America where they earn $7,000 a month. So we need to keep that flowing. That's the idea. If you keep that flowing, there'll be nurses in all the sectors. Maybe if private sector builds up, and that's why I'm engaging private sector, even challenging about the HMO business, because maybe if Filipinos had HMO, they'll have confidence to go to a private hospital. Then you'd unload the public hospital system. Then probably it will be better. For your information, Ayala Health is already not paying 14,000. Magkano na? 25 to 30,000 per month. Tama ba? Why? Because they have to compete. They have to compete with public sector. It's called the public sector, private sector comparator. They have to compete. They cannot get patients. They cannot get nurses if they continue to pay at 14,000. The ones that pay 14,000 are the mom and pop hospitals. These are the hospitals that have no credit line. They're running on cash flow on what the patients pay. And these are the ones na nahihirapan when PhilHealth delays their particular payment. So my answer to you is, it's still very complicated. The healthcare system is very complicated. There are so many cogs in the wheel, in the system. And if you change one, we pass universal healthcare law, we think it would be good. You know what happened to us at the ER of PGH? I had an ER that's good for 68 patients. I have 150 patients there. And you know where the patients come from? 1,000 of the patients every week, we have 5,000. 1,000 come from Cavite. 700 come from Laguna. When a person from Manila comes to PGH, I tell him, go to another hospital, I cannot accept you. So there's something wrong in our system because Cavite and Laguna is in Region 4A. It's another region with another governor, yet they come to Manila for their healthcare system. So So it even gets more complicated than the 60-40 split that you see on paper. Pero I don't want to lecture anymore. Maybe I should come back to the university and teach. but that's a good analysis anyway. Thank you.
Okay, ma'am. Yes, last question.
Okay. I'm not a doctor of medicine. I'm a doctor of philosophy. I was
a very good nurse.
I was teaching in Ateneo College of Business, MBA, under Father Bumaisel and Father Ed Martinez a long time ago. I'm now a columnist for Business World, and I would like to ask a very lay question. Being a journalist, I went out and interviewed a group of interns outside having a snack. And I told them, how long does it take to get a degree in medicine? They said 5 years because it's combined with an MBA. I was quite surprised. Being an MBA teacher, I said, oh, that's a strange combination, medicine and MBA. Then you will know about cost-benefit analysis, you will know about cash flow management, present and future value of your efforts, your career. It brings me to my question, which is we have spent the afternoon talking about the delivery systems of the healthcare system. The delivery, talking about it from the side of the medical practitioners, the healthcare givers, and it was the talk of Dr. Suit that mentioned about the sacrifice and the altruism that must be present in the medical profession. And my thinking is that the doctors are paid quite well. The nurses are also paid quite well compared to the other professions, careers here. But see, the medical profession, being a medical practitioner, they say it's not a career, it's a vocation. So, in my lay mind, this focus should also be on the end of the receiver. How expensive is it for the receiver of the healthcare? How affordable it is for the poor? How inclusive is this healthcare going to be for the less privileged in our country? See, when COVID struck, I have my column in Business World. I wrote about the increase in professional fees of the doctors. I think it was from 750 pesos at that time. It became 1,000 something, and it became 2,000 something. And then, I don't remember the exact facts. And then came online consultations, which was very, very expensive. And it's a kind of thing that you pay up front. So how can that help those underprivileged in our country? It's good to perfect the delivery system for health, but is it affordable? Does it make it even more expensive for the poor, the marginalized in our country? Perhaps, I was talking to my seatmate, Doctora, a while ago. Is this healthcare system a cooperative effort of businesses? Why not foundations, for example? See, so the profit aspect is less heightened. It's not, as you were talking earlier, is this health delivery a commodity? Is it a public good? So there is that debate there. See, this is unique. You have the Hippocratic Oath, don't you? When I wrote about that increase in pay, in professional fees, one doctor, neighbor, fought with me and said, how dare you talk about our increase in professional fees in a time of COVID where we sacrifice ourselves for the COVID patients. But see, it's difficult for perhaps to balance, as Dr. Suwit says. We have to balance, we have to be fair, we have to be all-inclusive. We have the safe that you said a while ago. Thank you for that, Dr. Suwit, because I think we should really focus on your criteria, safe, for a good health delivery system. Thank you very much.
Thank you for that thoughts and reaction. So I think we'll have to end this open forum. We've heard them, we've learned a lot from them, we are challenged, but it's one thing that we need to know and we need to do. We should be part of this aspiration to move forward and to implement the UHC here in the Philippines. With that, I would like to thank our panelists. Let's give them a big hand of applause. Okay. And of course, the sponsor of this summit, the Ayala Health. And for me, it's also a good learning platform that we know a lot of this reality that we have encountered now and soon we will still encounter. Thank you very much.
So the program isn't over yet, guys. I can see everyone leaving. I know it's kind of late, but we still have a few more parts of this program. But we'll get there. We're getting to the end already. Don't worry.
Yeah, so thank you very much again to our moderator, Dr. Salante, as well as our panelists, Din Dodi, Yusek Hans, Dr. Ken, Dr. Rosel, and Ma'am Gaget. Thank you as well to our audience members who posed their questions to our panelists. It was indeed a very productive and insightful discussion, and we hope that it can serve as a catalyst to inspire initiatives to address our different issues on HRH.
All right, so thank you so much again to our panelists. We request you can have your seats again. So, as we near the end of our program this morning, let us listen in as we hear a special message to be given by the Vice President for Higher Education of the Ateneo de Manila University, Dr. Maria Luz Vilches.
Good afternoon. We started with good morning, now it's good afternoon. But I would just like to say thank you so much for a wonderful discussion earlier. You know what we heard here. I'd like to acknowledge and thank you, our Secretary of Health, our keynote address speakers, and also our discussants, and all ladies and gentlemen here. We heard a lot today, and I think there's a lot to take in, there's a lot to reflect on. We had those images, the timba, we need to fill the timba, but also stop the leak so that we will not waste our energies. We also heard about how teaching English, is Dr. Suwit still here? I'm an English teacher and I feel guilty about that, but I think more than just English, I thought we were hostage to our fortune, but more than just English, I think there's a lot more that we need to do to keep our people here. And I was very pleased to say that we're also caring people, and I suppose that's part of the exportability of our own abilities here. So there's, as I said, there's a lot here, but it all made me think about how Ateneo de Manila, as an educational institution that declares itself to be a force for good, How does it hone the mindsets of students so that they become aware of the growing issues our country faces in terms of health-related matters? What is currently being done and what else can we do to influence the students to address these issues, especially when they embark on their professional careers? So it made me kind of reflect on what we're trying to do. At the undergraduate level, and for those of you who have studied here, the core curriculum, which is 79 units that's taken by everybody, there's a course on science and society which tackles societal issues that include health. We knew today that health, when we talk about health, we're not just talking about the responsibility of hospitals, we're talking about each of our responsibility is health. So this health society is a course that is taken by all students from all fields of discipline. While specific science programs in biology, life sciences, and health sciences directly deal with the topic psychology, socio-anthropology, economics, political science, and other related disciplines also influence students' thinking to look at healthcare not just as a medical but also as a public concern. Student organizations too are formative, especially, for example, these are just examples, Skype Ateneo, which takes care of cancer patients in children's hospitals, the biology students who go on a medical mission to rural areas, and many, many more. In a recent strategic planning workshop of the higher education cluster, we mapped out the initiatives and plans of the schools in the area of universal health and well-being as one of Ateneo de Manila's strategic priorities that Father Bobby mentioned about this morning. Currently, the Ateneo Graduate School of Business is offering an MBA in health, which is designed for leaders of health. We talked about leadership there on that up in the air, very, very treacherous with nothing safety net there, but what sort of leaders there are. So it's for leaders of health service organizations who would like to explore new paradigms for taking on the opportunities and challenges of a rapidly transforming public and private health sector. The Ateneo School of Government is upgrading its health governance electives and expanding its offerings around this area, also undertaking research on health governance, including tobacco control and governance. The Ateneo School of Government also supports the Doctors to the Barrios program of the Department of Health by giving them training in public management. The Ateneo Law School is crafting courses related to health and law in its JD and LLM programs. The Ateneo School of Medicine and Public Health, of course, takes the lead in medical and public health education. Its dual degree program already indicates the focus on public health as an important component in healthcare. They are producing not just doctors, but change agents in society in health leadership. They have a primary healthcare program called an Innovative Pilot Postgraduate Professional Development Program for Primary Physicians in the province of Northern Samar, which created a significant positive impact on the people's lives in the community. From this project was born the Rosita G. Leong Primary Healthcare Hub, which contributes to Ateneo's commitment to be a leader in our nation's quest for equitable health for all. I probably would like to reveal here, Dr. Dodi Alfonso, that the ASMPH is hatching a Master in Public Health program that is benchmarked with Mahidol University in Thailand and looks at a holistic approach to public health, thus the input and collaboration from socio-anthropology, health sciences, and other allied disciplines. I think it's going to be one of a kind coming up. I would suppose that part of the health issues that this program is going to tackle is mental health, which is another sector of the universe. In another sector of the university, the psychology department is focused on its NSTP or National Service Training Program involving undergraduate students. This is also tied to substance use prevention. All the professional schools of law, medicine, and public health, business, and government are also engaged with AC Health in its Consulta Package pilot project. This will involve the evaluation of the implementation of this program in some hospitals and clinics. At no other time than this, it is opportune that the Ateneo de Manila is blessed to have partnership with AC Health, such as in this summit and in the forthcoming research project and other future initiatives. that can enhance the contribution of both the university and a significant health partner toward addressing societal issues such as universal health care implementation. So I would like to thank AC Health, and here is Paolo Borromeo here, for its steadfast collaboration with us, the Ateneo Law School for taking the lead in organizing this event. You see, this event is rotated among the 4 professional schools. The HSB, Ateneo Graduate School of Business, the Ateneo School of Government, and the Ateneo School of Medicine and Public Health for their constant support for ALS in this endeavor for this time. I thank all the presenters and participants for your engaging presence. Whatever we do for the cause of healthcare, we inch our way toward progress. We take the cue from Thomas Carlyle. Thomas Carlyle is a Scottish essayist, historian, and philosopher who said, and I quote, "He who has health has hope, and he who has hope has everything." Good day.
Thank you very much, Dr. Vilches. Lots of exciting things to look forward to. Lastly, to formally close our program, may we call on the President and CEO of AC Health, Mr. Paolo Borromeo.
Thank you, and good afternoon, everyone. I'll make this quick because I know many of us just had taho and ice cream. First, guys, let's thank Secretary Ted Herbosa. He's a very busy man. But he stayed with us the whole morning. I think it's a testament to the summit, the content, the speakers, and also his dedication to working with different groups. Thank you to Ateneo, Father Bobby, who was here earlier, of course, Dean Joey, of course, VP Marlu, thank you so much, and the rest of the deans, Dean Dodi, Dean Randy, and Dean Jet. Thank you for the partnership throughout all these years, and thank you to the entire academic institution. I'm not biased, but we really value the partnership. To all my colleagues, actually, if I look around the room, mentors, advisors, friends, colleagues, all of us, in one way or another, dedicated to our craft, no? Which is hopefully to provide better healthcare services and products for our fellow Filipinos. Thank you for spending the time this morning. I just wanted to close with 2 thoughts. And as I was trying to reflect on today's sessions, maybe 2 things that just struck me. One is really the power of partnerships. Ang galing, di ba? I mean, you see different groups and different institutions from different parts of society, government, academe, nonprofit, LGU, private sector. And I think really COVID forced all of us to work together. And that's continued up to today, and it's evident in the discussions today. It's evident in the work that needs to be done, that is being done for universal health care, and it will be evident moving forward. It's evident in our private sector advisory work for the President with Secretary Ted, where private sector and the public sector collaborate to find joint solutions, especially for this nursing crisis. I call it a crisis because it truly is a crisis. And I think our journalist friend said it earlier. Let's not forget the biggest difference, kasi nangyari na to dati, di ba? Di ba, Gina, nangyari na to? Nagka-moratorium na dati kasi, nawalan tayo ng nurse, ang daming lumabas na mga eskwela, everyone started producing students, suddenly we had excess supply. But the one thing that's different this time is we just came from COVID. And COVID was a big game changer in the sense na ano siya para kang what do you call it, post-traumatic stress disorder, is that correct? PTSD? Tama yan? PTSD. So many nurses, it's true, right? You talk to many of our frontliners, and many of us here are frontliners. They went through quite a bit. No, so, and if you ask, and we do our surveys, the motivation was really low, the morale was low, ang dami talagang turnover. And that's different from the previous nursing shortage. So this nursing shortage will be long and deep. No, and we see it overseas because everyone's asking us for our nurses, as Gaget explained earlier. So it's important that the power of partnerships to identify collaborative opportunities to address this problem. It's these forums, these sessions, groups like the Private Sector Advisory Council working with the DOH and the Department of Migrant Workers. It's just very powerful what we can do. And so far we've had a few recommendations. We signed that clinical care associate agreement with CHED and DOH recently to promote clinical care associates. There are other initiatives that we have in the pipeline. But I think longer term, as Director Joe said, we just have to produce more. And in our mind, we have to produce 3 times as many nurses, 3 times as many doctors. And so that means every school needs to produce 3 times more. We need to have 3 times as many high school students wanting to be doctors. Everything multiplied by 3. Anyway, the power of partnerships. The last thought bubble that I just had for today, I'll go back to what Dr. Suit mentioned earlier, is the power of the spirit. And I think all of us, in one way or another, are leaders or managers or parts of organizations. Part of the challenge with this human resource issue is, I think we're addressing financial, we're addressing supply in the future, we're addressing career development. But I think Doc mentioned it earlier, it's so basic, but trying to nourish the spirit is so important and sometimes overlooked. Empowering people, motivating people, just asking people how they're doing, checking in on them. And many times, nurses, people will stay with you because their spirit is nourished and they want to stay with you. But many times we overlook that fact. No? And so siguro one quick win takeaway from today that all of us can apply in our own respective fields is how do I help my fellow colleagues in my respective organization and try to empower them. And more broadly, how do we invest, how do we build up our organization, our HR, our leadership capability so that we are encouraging and empowering and motivating people properly. That I think is the most basic, beyond adjusting compensation, beyond creating career development opportunities, beyond migration caps. It's how do we motivate people, and nourish the spirit. So with that, a big thank you to everyone. And please, let's thank the organizers. They worked long and hard. I heard even Dean Joey was in the trenches. But thank you to all of you. And on behalf of AC Health, I wish you everyone a good day, and we hope to see you in future events. Thank you very much.
Thank you so much, Paolo. So before we end this morning, maybe kindly request everyone to fill out our evaluation sheet. You may scan the QR code here or type in the URL flashed on screen. So once again, I am Dr. Rafa Abaya.
And I am Attorney Marian Agunoy. This has been the 4th Annual Health Leadership Summit. Thank you very much. Again, you may take your snacks, sandwiches. We're not sure if we still have taho or ice cream, but
I'm pretty sure there's a lot of sandwiches still outside, so make sure you take them home as you go to your afternoon sessions. Thank you.
Thank you.